morning and welcome to this update on the death certification reforms. My name is Susie Lishman. I am the Senior Advisor on Medical Examiners at the Royal College of Pathologists, and I'll be chairing today's meeting. So today's event is an opportunity for all of the government departments and other stakeholders to provide more detail about the upcoming death certification reforms. You will have seen the draft regulations and the accompanying overview that were published on December the 14th. If you missed it, there is a link at the top of your programme, and we will be referring to those throughout. Everyone speaking today and their departments have been working closely on these reforms, and it's a true team effort. Over 750 people have registered to attend today, and it's also being recorded so it can be watched by people who are unable to attend, and you can watch it again if you wish. I'm delighted to welcome so many medical examiners, medical examiner officers, coroners, coroners officers, registrars, crematorium medical referees, funeral directors, bereavement officers, and others. This really affects all of us and the bereaved people that we work with and care for. There will be an opportunity for you to ask questions. I saw somebody was saying, what's the point of me paying £10 to attend today if I can watch a recording? It means that you get the information immediately and you have the opportunity to ask questions. I've asked each of the speakers to allow at least half of their allotted time for questions, so there should be plenty of time, although I suspect not enough time to answer every single question that comes up. You'll see that there is no chat function and you're unable to unmute yourself or turn your video on. That's because it's in webinar format, which we need to be able to accommodate so many people. But there is a Q&A box and you can write your questions in there. With up to 750 people attending, it won't be possible to read or answer every single question today. To make it more likely that your question will be asked live, please read the other questions that people have already posted and upvote them. There's a little sort of thumb, I think, or arrow going up next to them. So if you want to ask exactly the same question, please just vote for it if you see it there, and it will move it towards the top of the list of questions. I'll be looking out for the most popular and relevant questions. And we've also received some in advance by email, which we may put to the speakers if there's time. Ideally, please keep your questions short. Some of the ones I've received by email are about 2 pages long, because I've got to be able to read them all and be able to ask them quickly. So the shorter your question, the more easy it will be to ask it. And also, please try to keep your question about the reforms in general, rather than a very specific point that only relates to your particular service or department. Please save your question for the relevant speaker if it's obvious who that is. So each of the speakers will be covering a section of the guidelines that were published with the draft legislation. And so if you've got those, you can see which bit they will be covering. There is no point asking the first speaker every question you've got about all of them, because speakers later on will be covering those areas and will be best placed to answer the questions. So, as I say, it's unlikely that every question you have will be answered today, partly because of time. It would take days probably to answer every single question, but also because not every answer is currently known or available. But I hope it gives you a much better understanding of the reforms and what they mean for you. If you have any technical problems, if you somehow get kicked out of the meeting and can't get back in or anything like that, please email the college team on the email address that you were sent the programme and the registration details, and the team will keep an eye out for those and do what they can to help you get back in. As I mentioned, the event is being recorded and you will be sent a link to the recording in the next few days as soon as it's available if you wish to view anything again. We will keep a note of all the questions that are asked in the Q&A, and we will pass those on to the relevant speakers and departments so that they are able to understand the questions that are being asked. And the plan is to publish an FAQ document, a frequently asked questions document, to accompany the guidance and this meeting, and that will clarify key points and answer as many of those questions as we can. This is not the only and final communication about the reforms that you will receive. There will be plenty of further opportunities to learn more about the detail. There'll be further communication as more information becomes available. And probably not another meeting like this, but through other fora that are easier for everybody to access without having to register. So we've got a huge amount to cover over the next 4 hours. I hope you enjoy the morning. Do please listen to the speakers. They have already received loads of questions, and they know the things that are worrying all of us about practical implementation of the reforms. So they will almost certainly answer most of your questions during their talks. So please do pay attention and don't spend too much time reading all of the questions that are coming up. And I'd like to now introduce our first speaker, William Vinell from the Department of Health and Social Care, who is going to give an update on the legislation, implementation plan and timetable. Thank you. William.
Thanks very much, Susie, and good morning, everybody. It's nice to meet so many of you today, and I'm glad so many of you are able to attend the event. My name's William Vinell. I'm a director at the Department of Health and Social Care, and I have two responsibilities. One is for overseeing inquiries and investigations that the department's involved in, and the other part of my responsibility is for policy on quality and regulation, litigation, health ethics, and also on medical examiners and death certification reform, which I took over responsibility for in 2019. That's obviously only 5 years ago, and I'm very well aware that a lot of people on the call today have been in this field for a lot longer. But what I really wanted to do today was, in a sense, to give an overview of where we're at and to annotate, as Susie said, the forthcoming events this morning, where you can see that the first half of the agenda is really people from the Department of Health and the NHS talking about the new system of medical examiners and the medical certificate cause of death. And then in the session after the break, the other equally important parts of the death certification system, explaining the changes that will be coming into their areas. And as Susie said, this is very much a team effort, and it is, with the best will in the world, quite complicated because we're changing a system that has been fairly extant since 1953, and there haven't been any huge changes since then. As everybody knows, these reforms were first flagged in 2007 when the Shipman report, Dame Janet Smith's response to the Shipman report came out, and since then have undergone a number of changes, but have been in sort of current format really since 2018 or 2019. We then had obviously a bit of a halt period for COVID, and since 2022, the pace of legislative change to enable these reforms has very much picked up, and that was what I wanted to focus on today. You'll all be aware of the many benefits of the new system of medical examiners being able to give an explanation and an answer to all non-coronial deaths, and to modernise the system of death certification reform. Obviously, this is a complicated arrangement. As I said, I'm going to run through some of the details in a moment, but I know, picking up on Susie's point about, we're all thinking hopefully about similar things, I know that what is on people's minds at the moment is, when is the new system going to start? Now, we've said from April 2024, and this is still the position, obviously being careful to avoid the bank holidays that pepper the spring. I can't give you a precise date for implementation now, but we intend to say more about the timetable in early March. So just stepping back on what's happened in recent months before I trot through the legislative details, it's important, I think, to recognise that the publication of the draft regulations was really quite a significant step, and was the government showing the position of what it's going to do with the medical examiners reform in really quite a lot of detail. And going back to what Susie said, there has been a huge amount of policy work, particularly since the end of the COVID period, that has got us to that position. A lot of joint working with the colleagues who are speaking later from the coronial system, from the Home Office, MOJ, from GRO, to sort out some of the difficult policy issues, including things like uncertified deaths. So the publication of the regulations in draft was a pretty significant step. We obviously published them in draft because we want to collate views on them, and today's seminar is very much another way of getting a wide range of views. So we will be interested in seeing how people come back with questions and the like, because that will be a strong indicator of what's on people's minds. I think it's fair to say that to date, the reception of the policy content within those draft regulations has been pretty good. I don't think people have been throwing their hands up in horror saying, this isn't what I expected, this isn't what you promised to do, these aren't the right things. So that's good. But obviously, we do want to hear if people have any particular issues they want to raise. And although it's obviously been a very busy news period, when the regs were published in the middle of December, they got very good coverage. It was on page 5 of the Times, for example, with a very straight reportage of the changes we were going to make. So we were quite pleased about the reception for the regulations. But as I said, keen to get views from people today. So publishing the regs was an important step, but wasn't the only step. Obviously, once we've published the draft regs and then we hear what people have to say, this will need to go off for sign-off and ministerial approval, and they then need to be put into Parliament. And there are a number of other logistical issues that we need to finally resolve with the new system. And that will bring us together, as I said, I expect, with the ability to give a more detailed timetable for implementation in March. And the plan after that is to put in some other session, not as big as this, but something that would allow a further communication at that point, potentially a podcast. We haven't quite decided yet. So that's a bit of an overview. And you'll be hearing from Department of Health colleagues. So the next speaker, David Hayward, is sitting to my left. And what I'm going to do now is say more about the legislation, the implementation plan, and then just regroup back on the timetable. So we did two things last autumn in terms of primary legislation. We commenced the relevant parts of both the Coroners and Justice Act, which does the full system of death certification reform, and the vast majority of the Health Act from 2022, which basically transferred the responsibility for the medical examiner system out of local authorities and into the NHS. And obviously, before you can do anything, you have to turn on primary legislation. And then, as I said, we published the regulations on the 14th of December, ourselves and the Welsh Government, 4 sets of regulations, 2 about medical examiners, 1 for England and 1 for Wales, 1 about the medical certificate cause of death, and 1 about the post of the National Medical Examiner. So 4 sets of regulations in total. And as I said, these have been percolating down with people. And today is part of the process of listening to what people have to say. Once we have done that, there are some more quite complex steps that we need to take in order to actually enact the legislation. The first thing we need to do is we actually need to bring into force the regulations, which would mean that all non-coronial deaths will become legally subject to a medical examiner's scrutiny. There is clearly a non-statutory system, which is headed up by Alan Fletcher, which is operating at the moment, but this critically will put the things on the statute book. And then we will make what we call consequential amendments to various regulations, the notifications of death regulations, which come from 1919, a much older set of regulations on registration of births and deaths, which are from 1987, and a set of regulations that concern cremation processes from 2008. So as a result of the legislation we introduce, those things will be amended. And then the other thing that we will do simultaneously is there will be some updates to the basic primary legislation. The Births, Deaths and Registration Act from 1953, which will accommodate basically the medical examiner system and put them into the wider context of death certification. Changes to the Human Tissue Act 2004, which will update references to the medical certificate cause of death, and the Access to Health Records Act from 1990, to add medical examiners where a patient has died to the list of people who may access a health record, which seems a pretty obvious thing to do, but is also quite important. So there is a lot of wiring and legislative changes that we need to make. But in a sense, the run to completing that process has been kicked off by the draft regulations, and we need to take the steps, as I explained, over the next several months to bring those into force. The medical examiner system is part of a broader death certification, registration and coronial process. As Susie said, it is very much a team effort. We feel that we have made significantly good strides, particularly since 2022, to resolve the funding issues for medical examiners, the legislative issues, and the logistical issues. And I hope that during the course of today and the forthcoming speakers, you will be able to understand in more detail what those changes are. And in the period after the break, you will understand what the changes are, maybe for the particular part of the system that you already work in. So that was all I really wanted to say, Susie. I think that was 12 minutes. And I'm happy to take some questions, which I might take in conjunction with David. But I hope that reassures people that there is a huge amount going on, first of all. It is very much a cross-government coordination approach. And as I said, we hope to see the fruition of that in the near future. But back to you, Susie.
William, thank you very much. While people write their questions in the Q&A, I had one that came in advance, which is what happens if a general election is called for early May, for example? How might that affect the statutory start date?
That's a nice question for a civil servant early in the morning. Well, look, I mean, if a general election is called, what basically happens is you have to do a sort of quick wash up of legislation and regulations in order to bring things to a conclusion, because you don't have an operative government during a general election period. So we would just have to take stock at the time and decide what we were able to do. Clearly, I hope, subject to what ministers say, that we would want to push on with this as far as possible, but we would just have to be pragmatic about it. I think what I can say is certainly the work that we've done to date, I think, puts us in a pretty good position to be able to cope with all eventualities. But clearly, we would need to tell people what was going on were there to be an election at that stage.
Thank you. One of the questions that's been posted is about the number of faith events and bank holidays and things that are happening in April, and how that might be a terrible time to implement a new service when there's so much else going on. Any thoughts about timing?
Well, as I said, we'll come out with a firm timetable hopefully in early March. Clearly, we don't want to do anything that reduces the possibility of us having an effective launch by clashing with any of those significant events. And I did mention that April and indeed the spring are peppered with bank holidays, and I mean common sense would imply that we don't want to do anything at a period where it is going to make things more difficult for people, or indeed where things are sensitive for different faith groups at different times. So I think my answer to that question would be, we're very well aware of those issues, and we will obviously exercise sensible common sense to make sure that we don't bump up against any of them.
Thank you. So obviously there's a lot of communication going on with people working in the sector, but how will this be communicated to members of the public?
Well, I mean, we will need to do a communication at the time that we actually, finally publish these things. There will almost certainly be a statement in Parliament, and I would have thought, government would want, to make its general points in the same way that we did at Christmas. And we are intending, and I may bring David in, to have some other communications which will be particularly focused at practitioners. So if I can just bring David in, who's sitting next to me and is my colleague in charge of the day-to-day activity of the programme. We'll be speaking in a minute, but David, maybe you want to come in on that question.
Thanks. This also serves as a mic test. Can you hear me okay?
Yes, thank you.
Excellent. Good. Yeah, so I think in the kind of near term, the majority of our communications is really going to be focused at the front line. So in addition to this event and meetings we're having with sort of representative bodies, you probably won't be surprised to hear that you will be reading about these reforms in the coming months in the primary care bulletin from NHS England, in that I imagine there'll be correspondence from Steve Powis and so forth. And the reason for that is because the people who need to know most about these reforms are the front line, who are responsible for implementing them in a matter of months. I think as we get closer to implementation, we will need to do some public awareness raising of it. you know, in some ways these reforms are a little bit behind the scenes, but there will be interactions between, you know, medical examiners and the public who will provide a service to the bereaved. And more importantly, it's, you know, and more broadly, it's important that people know what the process is, even if they're not, you know, even if the things that they as a member of the public need to do are not directly affected. So you know, we don't have a clear comms plan at the moment for how we talk to the public in general, but as William says, you know, there will certainly be a statement in Parliament close to the time, you know, when the regulations are laid, and we'll want to, and there'll be information on gov.uk, and we'll think about the best way to kind of get the messages out to those broader public audiences beyond the front line. But in the short term, I think our dialogue is most directly with the sorts of people who are on this call.
Thank you. One of the questions asked by a delegate is, in the statutory system, will there be any emergency ability for a death to be registered without scrutiny by a medical examiner or a coroner? For example, in exceptional circumstances such as IT failure or the system being overwhelmed, to avoid delay and distress for the bereaved. Will there be any way around this?
I don't know the answer to that off the top of my head, but I'm sure there must be something in the regulations or a situation that allows for that. Can we pick that one up, you know, whilst I'm not speaking, and we'll try and come back to it, because that's a really good question. So look, I'll take that one away, which is, you know, what happens in extremis. Thank
you. And I mean, obviously, you mentioned early on in your talk that you recognise that what people want to know is the start date, and that's not currently available. And obviously, you know, that's quite difficult for people trying to plan a service and make sure that everything's ready in time. One of the things I have heard is of people cancelling or not arranging their holidays for around Easter, for example, in April, in case that's when it starts. What would you say to them?
Well, I mean, I'd say a common sense thing, which is, I think, you know, you should take your holidays when you plan to take them, because it gives you a bit of work-life balance. And obviously, we will try and come out with a timetable, as I said, in early March. But I just, you know, I mean, if I was in your position, I'd carry on with my life, put it that way, not because, not for any other reason, but I just think, you know, common sense.
Yep, no, I think that's very sensible. One of the questions I've also been asked is, how will this be any different in Wales? So I wonder if I could take this opportunity to invite colleagues from Wales, and if I could go first to Natalie Harris from Welsh Government. Could you just let us know how things might differ, please, Natalie? And if Natalie's not available, then Jason Shannon, lead medical examiner for Wales, might like to start.
Yeah, he's there.
Thanks, Susie. Hopefully I can be heard.
Yeah.
So the importance of the legislation in Wales is that by and large it's entirely the same across both countries. The only aspect of the legislation that has been devolved to Wales is how they appoint medical examiners, but in terms of all the other processes, they would remain the same.
Okay, thank you. Just looking through the questions here. There's a question about how registrars are being engaged. So we have a talk a little later on about from the General Register Office. So that will be covered there. There's a question about, would there be repercussions if a death was registered without scrutiny? Would there be a fine, for example? I think the answer to that is it probably can't, as far as I can tell, it can't be registered without scrutiny. So if it were to go to the registrar would refer it back to the medical examiner. There's a question about funding and manpower planning for medical examiners, and I think that's a question really for the National Medical Examiner. Oh, long questions, which are quite difficult to read live. Let's see. Okay, I'm just reading the questions. Yes, will the recording be emailed to participants? Yes, so we are recording this, and as soon as we've done some minor editing to take out the break, we will email it to all of you who have registered. We will then, at some point, make it available on the college website via a link so that it can be accessed by other people. And there will be no problem with you sharing your version with colleagues who didn't register for today, because this is about sharing information and getting all of the answers out there, which is why there was no college meeting fee for the event. Just having a look through. What are the repercussions and penalties for GPs who refuse to give access to the records for the purpose of scrutiny? I'm not sure if this is one for you to answer. I think I know.
I don't know what the repercussions are in that sense, but obviously, you know, access is going to be an important part of making the system work. I know that we have increasing GP coverage, but we've got a little bit to do. I think we will set out in the regulations, in a sense, what the consequentials are if those records were not shared and that access is required. So that will come out in the final regulations.
Thank you.
I'd add that if it's helpful for us to address these issues in the guidance and other communications that we put out, then we can do that. Because not everything will be in the regulations, but clearly we can explain people's wider responsibilities. Probably not with too much of an emphasis on repercussion and penalties, but perhaps more of an emphasis upon obligations and ways of working.
Okay. Next one is one that I think I can answer. With the increase in other allied health professional roles providing services in primary care, is there a provision or future provision for non-medical healthcare professionals to complete the documentation? The answer is no. That would be a completely different regulation would be required for that. Okay, there's a question here, William. What is the block to confirming a start date? Why are you unable to tell us that today?
Well, I suppose there's two main reasons. First of all, we haven't finished the process of responding and going through the regulations, as I said. And secondly, we've just got to fine tune one or two logistical things. And when we've done both of those, we will be in a position to confirm the dates. I mean, just to expand in modest detail on what I said before, we formally have to go to ministers and then to Parliament to get approval to some of these dates. So there is a process that we have to operate, and therefore I'm not going to offer a firm date now until we've been through those procedures.
Okay, thank you. The question with the most upvotes is, can you reassure us that the implementation plan after March will take account of the time it will take to encourage GPs to refer and to re-educate them about the local processes? I mean, I think the obvious answer to that is this should be happening now. You don't need to wait until March to start getting your GPs on board. But would you like to add anything, William?
Well, I suppose, I mean, rather like you, the answer is people should be doing it now. But I suppose the answer is also yes, because we know that the uptake from GPs at the moment is much lower than it is in hospitals. It's about a third or something like that. So we do need quite a lot of progress on that front. But my expectation is that, you know, when GPs and everybody else, you know, see the final details and the dates, they'll move forward. So, you know, we need to be sensible about the position we find ourselves in. But we do, you know, it is a request that everybody out there in general practice, who I know are very busy doing lots of other things, you know, do look at these changes and get themselves prepared for what they need to do.
Thank you. I didn't see any mention of it, and I have no reason to believe there will be changes, but a question is, will there be any change to repatriation regulations or the paperwork?
Blimey. Don't know the answer to that one. Do you know the answer to that one, David? Otherwise we can go and check. No, I'm being told is the answer.
Yeah, that's my understanding as well.
So there we are, to know.
Will there be any additional funding for increasing the number of medical examiners and medical examiner officers?
Well, the funding's already there in the system. I mean, one of the things we achieved at the last spending review was to put the arrangements for medical examiners funding into the central budget of the NHS. So the money is there. And in fact, it was one of the other things that we were able to negotiate at the same time as we got the legislation through in April 22 that put this onto the NHS side. We were able to clear the funding position. So the funding is centrally funded and is in the system for both England and Wales.
Thank you. And an interesting one here is, what do you think the medical examiner system will look like in 5 years' time?
Oh, I don't really like speculating. I'm an official. I mean, look, what do I think the medical examiners system will be like in 5 years' time? I think it'll have settled down. I think it'll be respected, and I think most families and relations will think that the ability to get a good explanation, you know, at the point of death of their loved one is something very useful. And expected and normalized. I mean, this is an observation, but obviously, as I said, part of my job is dealing with inquiries and investigations. And one of the things you find time and time again in those situations is that part of the problem came from the fact of family or relations or friends not getting a clear explanation of a death at the point at which it happened.
Thank you.
Medical examiners addresses that head on, which I think will be a good thing. And I think you know, people will welcome that, and it'll be a normalized part of the system.
Another question is about funding of access to GP records. We've talked a lot about how, you know, over the years, about how medical examiners should be able to access primary care records to review deaths in the community. But there is a charge for many trusts for being able to access those and to have a license to access them. Is there any funding to cover that, please?
No, is the answer. There won't be any funding to access records from GPs.
Thank you. Yes, there's a question that about independence of medical examiners and conflicts of interest. And obviously, as we review increasing numbers of community deaths, and 100% of them in the statutory system, it would be easy for there to be a conflict of interest for a GP medical examiner who had worked perhaps in multiple local GP surgeries, trained locally. Will this be addressed in the guidance, the conflict of interest issue?
Yeah, I think the way we want to structure it is that people need to be sort of independent from the specific case they're scrutinising. So if there was a conflict, we'd expect it to be declared, and another medical examiner should scrutinise instead.
Thank you. A GP has asked, when are they meant to have time to do the extra work, given the workload they already have?
Well, I recognise the workload of GPs is busy, but obviously this has been a well-flagged statutory requirement that's been coming in for a period of time. So I would hope that it would be possible for people to absorb this within their workload. And obviously, the medical examiners will support the GP and doctors in the death certification process, so they shouldn't feel that they need to do it completely solo or in isolation. And obviously, you know, if people, you know, when we implement, if we find that you know, is an issue or related practical points or issues like that, then we need to hear from people. We're not going to, you know, we're not going to stop the listening and the interaction at the point at which the system is introduced. We will continue that because obviously, you know, we need to make sure the introduction is smooth, and we need to learn from inevitably what will probably be some teething issues which emerge whenever you make a significant change. But I do hope that this event and the other communications, the publication of the draft regulations, means that people can, you know, prepare themselves carefully for the forthcoming changes. They shouldn't, I think, be seen as a surprise.
Thank you. There's more of a...
Sorry.
After you, David.
I was just going to add, I mean, the requirement for GPs or, you know, or any doctor that meets the eligibility criteria to certify death already exists. That, you know, it's part of day-to-day responsibilities to be an attending practitioner when required. So that obviously isn't a new requirement. The thing that is different is as you know, the rest of us will go on to say in our slots, you know, rather than it being the responsibility of the attending practitioner to finalise the MCCD and then submit it, they will instead submit it to the medical examiner, who will then conduct that scrutiny and will then submit it. And, you know, so I think the question of extra work is not about the work involved in certifying a death, but how those discussions with the medical examiner are conducted, and very much about the strength of local relationships.
Thank you. There are a couple of comments rather than questions, but both of them I know you're aware of, but just to highlight that it is very difficult engaging GP colleagues, particularly when the start date keeps moving. And without any certainty about a start date, it's very difficult to maintain momentum and get people on board. So I know you're aware of that.
No, I think that's a fair comment.
Will the new system prevent another shipment?
Well, I think the new system is designed to ensure that there is effective scrutiny of deaths. I mean, nobody can guarantee anything in this world, so we've tried to address the issues that the shipment case raised as clearly and as sort of thoroughly as we possibly can. And I think, the scrutiny that we put in place is going to be effective from that point of view. Whether you can 100% deny that something like that will ever happen again, that's quite difficult.
Okay, thank you. I've got a lot of questions. Several of them are things that I know will be answered in the later talk. So if you've asked a question about coroners or registration or the MCCD, all of those have got separate talks coming up. And it would be better to answer those there. Just trying to scan. Okay, quite a few of the same sort of themes as that you already know about around about timing, and obviously we'll pass all these questions on to you, and they can be taken into account with the FAQ document and the final guidance. Okay, well,
I mean, the mood music I've got from that, obviously I wasn't looking at the questions, but Susie was pinging them back to me, was first of all GPs, capacity, time, awareness, making sure that we continue to focus on that, and then obviously the date ASAP, please. I think the other questions were largely important but technical things, and we've either answered them now or we will answer them in the future presentations. Look, thank you everybody for being so forthright. That's good. That's exactly what we want. And obviously we, as Susie said, will collate and take very seriously everything that we hear today and hopefully reflect that back in what happens over the next several months.
Thank you very much, William. And many of those questions that are still left unanswered, I'm sure will be answered over the upcoming talks. So I'd now like to introduce David Hayward, who you've already met, also from the Department of Health, who is going to talk to us about the role of the medical practitioner in the new system.
Thanks, Susie. So, yeah, I'm a Deputy Director in the Department of Health and Social Care, working in William's Directorate. I'm responsible for death certification reform, which we're talking about now, and also for clinical negligence and indemnities, which we're not. So that's me. In this section, I'm going to be covering the responsibilities of medical practitioners, and specifically in relation to certifying deaths. So I'm not covering the functions of medical examiners, which the next slot with Alan Fletcher is dealing with. It's an important responsibility for medical practitioners that have attended a deceased to complete an MCCD, providing their view of the medical cause of death. And this is part of the overall care road to a patient and is a key responsibility for doctors, whether they're working in hospitals or in primary care, and whether that's in the NHS or in the independent sector. And that's the case now, and it will remain the case when we introduce our legislation, but with some important changes to when a medical practitioner is eligible to be an attending practitioner, and also with the responsibility that will come to work with a medical examiner as part of the process. So on eligibility, we will be simplifying the current rules around when a medical practitioner can be an attending practitioner. So from when we introduce these reforms, any medical practitioner that has attended the deceased before his or her death will be eligible to be an attending practitioner and to complete a medical certificate of cause of death. And as an attending practitioner, they can propose a cause of death, providing they can do so to the best of their knowledge and belief. And this simplifies the current rules. So currently medical practitioners under the current regulations can be an attending practitioner and complete an MCCD if they've attended the patient during their last illness, which on the at one level is quite broad, but it comes with a sort of an oversight requirement, which is that they must refer the case to a coroner for review unless they've seen the deceased within the last 28 days or have seen the deceased after their death. And in essence, what we're doing is we're removing that 28-day limit and the need to refer cases to the coroner in those circumstances. And what this means is it will provide more flexibility around when a medical practitioner can be an attending practitioner, and it will remove what we see will be now be an unnecessary need for coronial oversight of those situations. And it's the involvement of the medical examiner in scrutinising deaths, all deaths, that makes this previous restriction and the coronial oversight no longer necessary in our view. And we ran a survey over the summer that sought views on this, and we met with a number of stakeholders, and that's helped us kind of get to this policy. I've mentioned the role of medical examiners. This brings me on to the second main change, which is the involvement of the medical examiner in the process. And I'll be brief here because I know that Alan is covering that role in more detail next. So it will still be the responsibility of the attending practitioner to complete a medical certificate of cause of death as they do now. Currently, this is solely their responsibility, and they currently have the legal responsibility to finalise the MCCD and submit it to the registrar. In future, it will remain a legal requirement to provide the proposed cause of death and other details and to initiate the MCCD. But the attending practitioner will, when they've done everything that they need to, will then submit those details and the MCCD to the medical examiner, who will scrutinise them, and it will be the medical examiner whose responsibility it is to finalise and via their office submit the MCCD to the registrar. That would follow any further discussion or questions that they have with the attending practitioner. So it remains the role of the attending practitioner to certify the death and to start the MCCD, but rather than finalising and submitting it themselves as they do now, that will be for the medical examiner who they will work with to support that process. And as has been alluded to, the majority of doctors in acute settings are already working in this way, and an increasing proportion of GPs are doing so, although it's not yet a legal requirement to do so. In addition, it's probably important to be clear, medical practitioners will remain responsible for notifying any deaths to the coroner that meet the usual criteria. And these criteria in the notification processes are not changing in any fundamental way. James and Heather from MJ will talk about coronial processes shortly. So a couple of things to add. The regulations on the MCCD that we've published in draft, they set this out in more detail, at least in terms of articulating these things as legal responsibilities. And of course, there will be updated guidance that we make available in the coming months to set out those individual responsibilities, including for medical practitioners in more detail. So that's the summary I wanted to give, and we can now deal with any questions. If those questions are very, very focused on the medical examiner role, it might be best to leave those to the next section, but obviously there's collaboration between the two.
Okay, thank you. What I'm realizing is trying to monitor questions from 700 people is extremely difficult. A lot of these are going to be answered later or are not related to the regulations. Yeah, lots of questions about cremations and crematorium medical referees. If you have a look at your programme, you'll see that there is an entire section on cremation. So it'd be great if you could save your questions about that for that section, please. Okay. Very difficult to pull out relevant questions from all of these. Just some practical questions about actually having to submit the MCCD to the registrar. Does it have to be done by the medical examiner office now rather than a bereavement office? So just a practical question, is that going to be mandated, or will it be up to local practice to do it in the way that works for them?
Alan may want to cover that, but I think the key thing is that it will no longer be the responsibility of the attending practitioner to finalise, their responsibility to certify the death. It's not their responsibility to finalise the MCCD and submit it to the registrar. The medical examiner has that legal responsibility. It will be done through their offices, and Alan can expand on how exactly that works if he chooses to.
Okay. Oh gosh, there's some questions that go over more than 2 boxes, which are just impossible to read in the time available. Yes, there's questions about registration, again, which will be covered in the registration talk. Also practical questions about how the MCCD is actually sent. Is it an email? Is it a hard copy? I think, I don't know if that's something that you can answer now. I think one of the things that occurred to us, if it's got to be emailed all over the place and it's not a PDF document, it's repeatedly being scanned and printed and signed and then rescanned and emailed back and so on. Does that have to happen, or is there an easier way to do it, please?
I have a section on the MCCD, but I'll cover that now because it's an important question. At the moment, you have a paper MCCD. I believe since 2020, it's been possible to scan that in or capture an image and electronically transmit it. And I believe that's probably how a lot of people are doing it at the moment when they're, engaging with the medical examiner to share the MCCD. So it's possible to do it by hand. It's also possible to do it electronically, even though it sort of initiates as a paper form. As I will go on to explain later, for the MCCD, we will need to make it available as a paper document, and some people will want to use it in that way. It will still, as it is now, be possible to scan it in and send it, and we're looking at everything we can do to facilitate that process, including sort of PDF availability, but we'll need to set out in more detail soon how we're making those MCCDs available, including all the nuts and bolts of when trusts can expect to, I say trusts, it won't just be trusts, but when, the frontline can expect to receive their hard copy MCCDs, and also the additional stuff I've just been mentioning.
Thank you. There's a question about, in hospital practice, the medical examiner office often know about a death before the attending doctor does. And so the medical examiner office initiates the process of review. Is that still allowed? Because it sort of implies that the attending doctor has to get in touch with the medical examiner office rather than the other way around. Does that matter?
If you look at it from a no, it doesn't matter. But what I would not expect, at least not in terms of how the process works as per our regulations, is for the medical examiner's office to be initiating the MCCD and filling in all the details and saying what they think the cause of death is. That's the responsibility of someone who's attended the patient. Of course, in terms of how the death is brought to the attention of everybody involved in that process, frankly, I think it's good that it's not 100% that it's not 100% reliant on the attending practitioner learning about it and then being solely responsible for initiating the process. And if the medical examiner's offices are learning about deaths more quickly, that seems to me it then allows the steps that then need to happen to happen all the more quickly. But it's the role of the attending practitioner to propose the cause of death.
Thank you. And I think a follow-on question, which I think the answer is straightforward. Would it be reasonable? Would it be possible for the medical examiner officer to confirm the content and finalise the MCCD under delegated authority from the medical examiner, or does it have to be the medical examiner themselves?
I'm going to leave that question to Alan,
Yeah.
either now or in 10 minutes time, because that's solely about the responsibilities of the medical examiner, which he's going to be talking about.
I think I'll just answer it and say it has to be the medical examiner. So it has to be signed by a medical examiner. So there won't be any way, I don't think there'll be any way for anybody else to do it on their behalf. I think that's one of the things that the medical examiner will have to do. Okay, just going back through the questions. A lot of them from the previous talk, which I'm going to probably have to put to one side so that I can see the current ones. Yeah, I think that something that's coming up a lot, and I don't think you'll have an answer for it, is the one about conflict of interest, which I also asked William. I think once the doctor who can issue the MCCD is expanded to any doctor who attended at any time during the lifetime, that then introduces increased risks of conflict of interest for the medical examiners, because essentially you're saying the medical examiner can't engage with the doctor or the partner of anybody who ever saw the patient ever. And that may rule out an awful lot of people. I don't know if there's anything you can say about that, but I think we're going to need some quite detailed guidance about conflicts of interest.
Yeah, the medical examiner should obviously flag up genuine conflicts of interest. I don't think there's again, Alan can expand on this if he chooses to later, but I don't think there's an expectation that the medical examiners involved in the process have never met or never worked with the doctors whose deaths they're scrutinising. It's it's about has the medical examiner been involved in the care of the patient and the need for independence from that. I'm not sure that I suppose I'm not persuaded that widening the eligibility criteria as we are for who can be an attending practitioner increases that risk, but it's something that we can look at and address when we do the guidance.
Yeah, there's a lot of questions here about independence and why is there any difference in general practice when many medical examiners are employed by the trust in which they work as consultants. Okay, lots of questions there that are not relevant to to this bit. I mean, I think we'll have a look at, we'll discuss in more detail later the issue about who is eligible to complete an MCCD. That's for a later talk. Lots of questions about funding, which are not relevant to this bit. Question that keeps coming up is do we have a definition of attending doctor? What does attending mean? How much or how little does one have to do to have attended?
So the thing that we're changing is the time period, but I think yeah, again, we can address that in guidance, but we mean people who have supported the care of a patient in some way. If this was you met them in a corridor for 1 minute 20 years ago, clearly that probably doesn't feel like a strong enough connection. And I think that this is where the kind of the other element would come into play, which is that you're eligible if you meet the criteria, including if you feel able to propose a cause of death, which is a judgment on the part of the attending practitioner themselves, based upon their sort of familiarity with the case and their view of their ability to propose a cause of death. So I think people shouldn't, if that connection isn't strong enough and they don't feel competent to propose a cause of death, then they shouldn't.
Okay, thank you. Whose responsibility is it to identify the attending doctor? Is it the medical examiner team, the bereavement team, the practice? Who has to identify them? Particularly now, if this is opened up and there are multiple potential attending doctors, is there an order in which you should approach them, and who decides who it is?
So, I mean, for a death in a hospital, the process would start with the hospital consultant. Um, I understand, and for GP practices, the process would start with the partner GP, and what they will be both looking for is, medical practitioners that have attended the deceased, and there may be more than one, of course, and from within those, identify the person who's best placed to be an attending practitioner. Um, where that's not possible, I think there would then, well, we go on to talk about the scenario where if no attending practitioner can be found, so that's covered later. But I think the point of widening the criteria is that rather than it being quite a restrictive potentially set of rules on who can be eligible, there's the potential for anyone who has attended and feels competent to do so to step into that role.
Okay, thank you. Well, just looking through the questions, an awful lot of them are not actually quite relevant to your talk. So I think we'll move on and we'll address them in the upcoming talk. So David, thank you very much for that. We're now going to go to Dr. Alan Fletcher, who many of you will know, the National Medical Examiner, to hear more about the role of the medical examiner and officer in the new system. Thank you, Alan.
Thank you very much, Susie. I thought I'd try and break things up a little bit by having some slides. So if you bear with me a moment, I will attempt to share my screen. I hope that works.
Yeah, that's fine. Thank you.
Great, thank you. Good morning, ladies and gentlemen, and everybody. Thank you so much for joining this, a real milestone event. And I've got my remit is to talk about the role of the medical examiner. And you'll notice that I added medical examiner officer into this title because, as far as I'm concerned, they are an essential, integral person in the system at the moment and in the future statutory system. They have delegable responsibilities, and that hasn't and will not change in the statutory system. Just by way of clarification, it is my understanding that medical examiner officers are not mentioned in the draft regulations because they aren't mentioned in the primary legislation. It doesn't mean that you officers are overlooked at all. Quite the opposite. You're essential. Now, listening to the previous talks and the questions that are coming in, I thought it's worth reflecting that I know this day is about what's new, but it is also essential to say what is going to be the same in the new system, and that is a lot. We have lots of systems and aspects of this process in lots of different locations that is working very well, and I am keen that the legislation does not interfere with what is working well. If there are, for example, local arrangements where a bereavement services identify an attending practitioner, or a medical examiner office starts their scrutiny before a practitioner is available to complete a medical certificate of cause of death, there are components of the process that can happen flexibly, and it's really important that we maintain that. The reason, primarily, is not for the convenience of everybody working in the system. It's to make sure that bereaved people get to where they need to get to at the early stage. This is a system that's for bereaved people. So with that in mind, I wanted to just touch on some of the things that stay the same. And scrutiny, as you will be aware, seeks to answer these three questions and undertakes it in 3 steps. There is no change to these questions or their steps. There may be variation in the order in which they may occur, those steps, but the steps remain. And I reiterate, it's really important that we continue to have some flexibility in local practices to make sure that we can fulfill the requirements. What's come up a lot, I might have guessed it, mightn't I, was the question about independence. And a few reflections on this from a medical examiner perspective is that independence is core to the system. It's core because it is what is generating public and stakeholder confidence in the work that is being done. And it is also worth reflecting that currently there are 126 offices in England and an entire country system in Wales that are scrutinising approximately 2/3 of all deaths, which makes me think that independence is currently well established and working well. The regulations do provide an opportunity to strengthen the current independence of medical examiners and officers. And at this point, I think it is also worth emphasizing that guidance that accompanies the regulations is essential to help people understand their roles and responsibilities. Because statute is the regulations themselves are a very stark set of sections and clauses which have to be future proofed. And there's lots of things that change in the NHS and working practices on even a weekly basis, never mind annual. So guidance is going to be everything, and we will put in that the important things, the important messages that are coming through from today, the sense check, the questions, the queries, the challenges, to make sure we get that clear. Attending also appears in the medical examiner regulations, and the definition of attending, as was rightly asked just now, is not clearly defined in law. But from my point of view, it means provided some medical attention to a person at some point, and I think that's important. If you've provided medical attention to a patient, then it's difficult to see how you can be perceived as independent. However, I am as I have learned to become in this process, pragmatic. And therefore, asking about conflicts of interests and questions and queries about that, what that means, is sensible to err on the side of caution, to record the conflict of interest if there is one, and ask a friend, ask a lead medical examiner, ask a colleague, or if necessary, ask the regional medical examiner and regional medical examiner officer as well. That way, we can make sure that we've got records, local reviews, and learning and refinement of that as we go forward. I also guess that access to records would come up. And it's plain, of course, that access to medical records are essential to conduct scrutiny. Remember, this is to be proportionate and relevant to the case. We currently have, in the non-statutory system, provision under the section 251 to be able to have access to records and for access to be shared with us. And this is going to be superseded, as was just described, by an amendment to the Access to Healthcare Records Act from 1990. We're going to have to set this out more, what this means in detail, in more guidance, but ostensibly it means that medical examiners have a right of access. I heard the question, what happens if somebody refuses? Well, a medical examiner, in my mind, cannot conduct their scrutiny and therefore cannot confirm a cause of death, regardless of what may be proposed on the medical certificate. I think it's important to remember that security and information governance will hold, as they do now, an extremely important place in security. And we're working with colleagues to refine and update and do our level best to provide more seamless access, building on local practices to records. Signing and sending the medical certificate of cause of death. This will be a new requirement in the statutory system. A medical examiner must confirm the cause of death when they are able to, and I'm going to come on to what happens if they struggle to do so in a moment. they will have to sign a declaration to the best of one's knowledge and belief, like it is on the medical certificate now. That declaration means, in my mind, uh, based upon a conscientious appraisal of the known facts. That is not every fact, not every single piece of possible available information. It is what they know at the time and to the best of their knowledge and belief. That is a satisfactory position from my point of view. Another question that comes up about eligibility and the practicality of doing this when I know that the scrutiny process may span more than one medical examiner session, which isn't guaranteed. Again, we'll set this out in guidance, but as far as I'm concerned, provided the steps of scrutiny have been concluded, including by different people, it might be a part of those by a medical examiner officer, the interaction with a attending practitioner, for example, that another medical examiner can confirm the cause of death, sign that declaration at the completion of scrutiny if the first one is not available. They have to be satisfied that the scrutiny has been conducted, of course, because that's what the declaration means. There is the practical issue about the physical method of a signature being added to a medical certificate, which I appreciate is a conundrum. This session is all about regulations, and the operational practicality is got to be sorted out. I'm working with colleagues, especially in the Department of Health and Social Care, about how to resolve this, and we'll be in touch. And then my final point is about the timescales, because the regulations say mention things like as soon as practicable and without unreasonable delay. And people ask reasonably, what does unreasonable mean? There is some legal precedent on that, and we will set that out in guidance. I think standing back, however, one needs to recognise that a bereaved person wishes to proceed with their funeral arrangements as quickly as they possibly can. And this is an important component of that process. There are all sorts of repercussions downstream for coroners, coroners' officers, registration services, and the Department of Work and Pensions, for every reason for this to be undertaken as quickly as is practically feasible. And I'm sure that that's what is currently being achieved in very many offices. Communication is everything, of course, and I've talked about a triangle between medical examiners, medical examiner offices, that is, coroners and registration services. This will need to be strengthened, but adjust slightly in the new system. The attending practitioner will need to notify if a medical examiner office is not automatically notified about a death locally. It will be their responsibility to do so. And the interaction with a medical examiner office can be delegated. It can be where things are straightforward, not necessarily an in-person or telephone discussion, although that's always available, should be. There will also need to be a change where between medical examiner office and registrar, where the registrar will come back to the medical examiner office with queries. So we will build on the excellent communications that are currently in place in very many offices, already well established with local registration services, thankfully. And then finally, the communication between medical examiner and coroner we do this now. We need to build on this and build mutual respect and trust. I'm delighted that there is an opportunity. The regulations will say that the reasons for notification to the coroner and the coroner back to the medical examiner will need to be made clear. And I think that's a strength to this of openness, understanding, and transparency. How that is achieved, I'm going to defer to James Parker from the Chief Coroner's Office a little later. Okay, so just going to turn on to disputes because I suspect this is also going to be asked as a question. What about where there is a disagreement between the QAP and the medical examiner? I'd ask you what happens now. And what I understand is after over 640,000 deaths scrutinised by medical examiners, this is a rare event, and that usually, almost always in those rare events, the differences of opinion are respected and resolved through discussion and pragmatic negotiation. Disagreements about these sorts of things and difference of opinion are familiar to doctors. It occurs all the time in clinical practice. I don't see this as any different, frankly. I would hope that in the majority of cases this can be resolved, if necessary, with escalation and mediation. If it becomes a pattern, then that needs to be addressed in a different way. Ultimately, I suppose if the cause of death cannot be agreed, then the cause of death is unknown, and that's a valid reason to notify the senior coroner. But I would say that is the end point, last resort of these kinds of dispute. And again, I just reiterate how important it is to remember that bereaved people are in the middle of this dispute. They have a view too on the cause of death that should be respected, and we should remember that disputes can delay their processes, and we should avoid them where we can. I'm not far off done. Some queries about registrars and if the registrar queries the medical certificate content, if there is missing information, well, what do they do now? They will approach the attending practitioner or liaise with the bereavement office staff or practice to ask for something to be amended or to complete it correctly. But if there's a query about the cause of death, then that should come back to the medical examiner office. And I think that's a really positive development. It's a logical step in my view, and I'm sure that relationship will grow and blossom as a result of it. There's no reason why that can't happen now from a pragmatic and practical situation in the non-statutory system, but that isn't actually a statutory requirement for registrars who have a route currently to refer these cases to the senior coroner. It is my understanding that will change, and I'm going to pass that on to the registration service talk a little later. And then finally, what about between coroners and medical examiners? And again, I'd ask you, well, what happens now? These are usually resolved through discussion and negotiation. Medical examiners will continue to respect the coroner's judicial decision. It is a judicial independent decision. It carries a different weight to what the medical examiner's scrutiny has here. But ultimately, I suppose, if the coroner declines to investigate what a medical examiner may consider to be a death with unnatural features and the cause of death is determinable, then that's what should be written on a medical certificate. So I suppose if a certificate says subdural hematoma, then so be it. However, I don't think these things are going to arise at all often. Instead, what we've got is an importance of the coroner and medical examiner to discuss a case, as they always have done and always do. As you can see, the photograph that I've chosen here is a picture taken of me and the Sheffield coroner when I started this journey back in 2008. So next about employment. You will have noticed that the regulations stipulate that an NHS body or the Welsh equivalent must appoint and employ the medical examiner. There is no scope for any other provider setting up a parallel system. I suppose there is a reset check opportunity for that contracts are fit for purpose for the statutory system. I would expect some of the contract clauses that are written in the terms of appointment and employment and termination of appointment to be pretty standard HR kinds of things that are probably there anyway, but it's an opportunity to do a sense check. I don't see anything controversial about matters of professional standards being a valid reason to terminate an employment. but we'll cover most of this in the guidance that follows. Penultimately, training. Um, training for what the new system entails and the steps are, of course, required. I would consider it more for those who are currently working in the system about preparation and familiarization of what's coming. And I think that can take a number of ways, approaches. For example, attending this event today is one good way of doing it. Other ways might be reading appropriate documents or looking at refreshed selected e-learning modules. And just a word on that, and Susie can add at the end if she wishes. There is a need, of course, to refresh the e-learning modules so that they reflect the statutory system, the core modules in particular. I want to state very clearly that I do not see any requirement for any medical examiner or officer to redo those modules. There will be no requirement, but I will set out in guidance what is needed. That's different for new appointments, where they will need to have completed those core modules before starting work and have attended a face-to-face session within a defined period, for example, 6 months. So my last slide is about myths, and there is only one really, and that is that unlike Osiris, the Egyptian god of the dead, there will be no mandatory requirement for an external examination of the body of the deceased by a medical examiner or a medical practitioner, but it remains an option, and I think that's an important safeguard. Okay, so in summary, I'm just going to stop sharing. Excuse me, I'll try to stop sharing. No, I can't stop sharing. There we are. I've stopped sharing. I think I have stopped sharing. I beg your pardon. In summary, getting to this point has felt a little like a Sisyphean effort at times, but the regulations are an important milestone, as William has said. Much will be the same for medical examiner processes, but there are a few important facilitatory changes to make this more consistent and fit for purpose. Thank you for listening.
Alan, thank you very much. I've been going through the questions and I've pulled out a few for you. So hopefully we'll answer a lot of those that have been asked. You certainly already answered the one about, will current medical examiners have to undertake more training? They won't have to redo all of the e-learning modules. I know you addressed it, but I think just to flag that one of the things people are most worried about is if the attending doctor and the medical examiner disagree about the cause of death. And you can just imagine that if the attending doctor feels able to issue the MCCD and tells the coroner that the coroner would be very happy for them to go ahead and do it, but that makes it very difficult if the medical examiner doesn't agree. So I think in practice, that's going to be a real challenge. I don't know if you want to add anything about that.
Well, I think that's something that we encounter from time to time now. I put it this way. I think there are a couple of ways of looking at it. One of which is there's mutual trust and respect, and there is that people are entitled to their opinions. I think that is also there is also an important connection and communication with coroners, that medical examiners, and relationships that they have. I also wonder whether or not the difference of opinion is so critical to the case that makes all the difference of adding a word or two that makes no material significant difference to the overall cause of death from a registration perspective. And in short, there is a time to pick one's battles. But if there's a fundamental disagreement, then ultimately that's that I think that where it comes down to local resolution and each case is unique.
Thank you. It's another question about, I suspect in the statutory system, when every non-coronial death is reviewed, there may be some blurring of the lines between who attended the deceased. So, for example, if somebody comes into the emergency department and dies, then would it be appropriate for the medical examiner to go to the GP practice rather than the emergency department doctors to issue the MCCD?
I well, I think there are I think there are a number of different options. My thought was that the best person to write the medical certificate of cause of death is the person who can best identify the cause of death. And I think that there are times when, in an emergency department, for example, being confronted with the ECG changes of a myocardial infarction makes them a very well-placed person to conclude that the cause of death. But if there's somebody who has cared for their patient for years with a chronic disease, it may well be that a GP would see that as their role and responsibility rather than an attending doctor in an emergency department who may have met somebody for a matter of minutes. I think there's, again, the compassionate human pragmatism is the way I would see that developing.
Thank you. The regulations seem to suggest that only the attending doctor would refer a case to the coroner. Will it still be permissible in some circumstances for a medical examiner to refer a death to a coroner?
Thanks, Susie. Yeah, my view has always been that the attending practitioner is the right person to make a notification to a coroner because they know the case. However, they're not always able to do so in a timely manner because of their own commitments. And in those circumstances, I think that where there is something that is less controversial, let's say an industrial exposure reason to lead to coroner notification, as an example, that a medical examiner office can facilitate that, whether that's making the referral or not. And then finally, there is that point that the Notification of Deaths Regulations 2019 say that it is the responsibility, the duty of any doctor who knows that a case needs to be notified to a coroner, that they undertake that notification. And medical examiners are doctors. If they know, then they have that duty.
Thank you. Not a question as such, but there have been a lot of comments about the lack of independence of medical examiners, particularly if they're employed by trusts. And I think there's a lot of overlap with the conflict of interest discussions that we had earlier. Are you able to give a little bit of background as to why, we've been asked several times, why are medical examiners not being employed by the ICB or the local authority, for example?
Okay, well, these are policy decisions taken that were not my decisions. That sounds like almost like a civil servant duck out, and it's not really. I think I'll put it bluntly: if employment of medical examiners were to sit within local authorities, I don't think we would be anywhere near where we are now. I don't think we would have any kind of system of medical examiner review involved, and that would be a tragedy. From the point of view of large organisations like ICBs or NHS England employing large numbers of, they just simply don't do it. There isn't the infrastructure to be able to employ thousands of people to be able to do this. It's not what they do. They appoint people and employ people, but not doctors. So it would risk a lot of challenge of achieving it in a timely way. Speaking candidly, and then. Just to address the last point about, well, but what about the people working in trusts? Is there a problem? Again, I'll come back 640, 700,000 cases later. It's not, it is not, this is not being raised as a big issue because, in my view, we have an exceptionally committed, motivated, professional group of doctors and officers who behave with the utmost integrity. so as to make this independence question redundant.
Thank you. I've got
Can I just come in?
Yep.
Can I come in on that very quickly, just to sort of support Alan? So obviously, as I said, I've been involved in the latter stages since 2019. But one of the reasons why we had the lag of time from 2007 to 2019 was that we originally had a situation where this thing was going to be operated out of local authorities, and the government decided that was a bad idea. And it was completely logical for it to be in the NHS because it's about deaths, it's about medical examiners, medics exist in the NHS, and that was generally thought to be sensible. So we certainly don't want to unpick that. Well, we can't unpick that. We certainly don't want to, and it was done for good reasons. So in a sense, that's the sort of legislative kind of policy background in broad terms. I'm not as close to the questions as conflicts as others are, but as Alan has broadly said, I think the way we have set up the new system means that if there is a patently obvious conflict of interest like the one I was asked about in my early questions, you would use your normal judgment and all the things that are in good medical practice and all the codes for doctors to do that. But there is nothing structurally unsound about the way we are setting up these arrangements within the NHS.
Okay, thank you. I have got a lot more questions for you, but unfortunately we haven't got time to look at them now. If we have a chance later, we will come back to them because now we need to come back to David to hear more about the medical certificate of cause of death, and a lot of the questions actually relate to that. David, thank you. Thanks, Alan.
Thanks, Susie. Would you be able to put me on video when I try to? It says that the host has stopped it, and that's probably because I didn't turn my camera off previously.
Okay, college team, are you able to turn David's video on, please?
Thank you. I now have
Thanks.
permission. Excellent. So as we sort of covered previously, the MCCD will still be used to capture the cause of death as agreed between the attending practitioner and medical examiners, and it will continue to form part of the document required by registration services when they register the death. I'll recap briefly what roles and responsibilities will be for completing the MCCD, and then I'll talk about the new forms and what's the same and what's changing. So in terms of roles, keeping it simple, as we were talking about earlier, the attending practitioner will be responsible for initiating the form and proposing a cause of death. So they will start the process of completing the form, and most of the fields in the form are for them to do. They will then submit the MCCD to the medical examiner for scrutiny, and the medical examiner will liaise with the attending practitioner to conduct, as needed, to conduct that scrutiny process and to then finalise the form. The medical examiner will add their details, which I'll get onto, and their responsibility will then be to submit the form to the registrar through the medical examiner office. And then finally, the registrar, will know that they're going to receive it from the medical examiner's offices, and it's the MEOs that they will liaise with in the case of queries rather than with the attending practitioner. So that recaps the basic responsibilities for completing it. Of course, this is, this reflects the involvement of the medical examiner at the moment. At least if you go by the letter of the law, it's the attending practitioner that has the responsibility for completing and submitting the form, and that will no longer be the case. There will then be, so to support this, in the statutory system, a new version of the MCCD will replace the existing certificates to reflect the introduction of medical examiners and their scrutiny function. So I'll summarise what's remaining the same and what will be new. So there'll continue to be several versions of the form. So there'll be a statutory form to be used when a death occurs after 28 days of life, and there'll be a separate form that's used instead when a live-born child dies within the first 28 days of life. Both of those forms will be available in bilingual format in Wales. And in addition, the MCCD will continue to include details of the attending practitioner who certified the cause of death to the best of their knowledge and belief, as it does now. And it will, of course, include all the details of the cause of death. So all of those aspects are remaining the same, and it's really about what we're adding. So the new MCCD forms will include the following new information. So crucially, the MCCD will include details of the medical examiner who scrutinised the cause of death. So this will evidence that the scrutiny has taken place and that the cause of death that is recorded represents that agreed between the attending practitioner and the medical examiner. In addition, the MCCD will capture some new information which will be provided by the attending practitioner when they're, certifying the death. So it will include ethnicity, as self-declared by the patient on their medical record. If the patient medical record does not include information on ethnicity, then the attending practitioner can complete it as unknown on the MCCD, and there's no expectation that they then ask for this information from representatives of the deceased. And then to bring the MCCD in line with international standards, there'll be some additional fields. So that includes information on maternal deaths. So was the deceased pregnant, and was that a contributing factor, if relevant? And there'll also be a new line D, which is essentially an additional line to allow additional detail on the cause of death to be provided. And then finally, information on medical devices and implants will be recorded on the MCCD by the attending practitioner. And this will then be transferred to the certificate for burial or cremation contained in the green form, completed by the registrar in order to inform the relevant authorities of the presence of any devices or implants. So those are the additional fields that will be on the new forms. There was a question earlier around how it will be made available. So the MCCD is currently available as a paper document. Since I think 2020, it's been possible to scan and electronically transmit the completed form. And this has supported attending practitioners to share information with the medical examiner in the current system, and and will continue to do so. And it will facilitate submission of the form to the registrar. A new paper version of the MCCD will be distributed out to healthcare organisations before the introduction of the statutory system. We'll be setting out more details of how this will be made available, and the distribution arrangements to the NHS. So, I mean, in basic terms, there's a logistical job for the department that will involve distributing new booklets of forms to the healthcare organisations that will need access to them. And obviously, we'll be letting those organisations know what to expect and when they'll receive these things. And we'll also be setting out more information on the processes for completing the MCCD, which will also be set out in guidance. And as I said earlier, we're looking at the introduction of a PDF MCCD to facilitate electronic sharing. Although, as I've said, the paper form as it is now can be scanned in and transmitted in that way. In addition to this, but more for the longer term, we are developing an online version of the MCCD, so what we tend to refer to as the digital MCCD, and this will enable the form to be in future more easily shared between the attending practitioner, medical examiner and registrar, and again over the longer term would now allow for some sort of analysis of some of the data that gets collected in aggregate on, via the MCCDs. So this is more of a web-based and database sort of focused system, but this is not something we're talking about making immediately available. We'd expect it to be available later in 2024. Couple of additional points. The draft MCCD regulation we've published sets this out primarily with reference to roles and responsibilities, but also the types of data that will be included on the MCCD, and there'll be updated guidance on the MCCD that we'll publish soon. That's my summary, and happy for any questions.
Thank you. We have lots of questions. Have you got, I know you mentioned it, lots and lots of questions about the electronic MCCD. Might it not have been better to wait until that was available? When do you think it will be ready? And will it be possible to see the new MCCD soon so people can have a look at what it's going to look like?
So yes, I think it would be very useful for us to basically expose the proofs of the MCCD so that people can see them. That will need to be in the guidance. It will also be in the regulations. And if we're having a further event of this type, then or frankly, any of the other communications that we do, as soon as we've got a finalised version, I think we'll want to share what that looks like. And there was a question on I suppose I'd distinguish between what we can do in terms of basic PDF versus something that's more complex and available over the longer term. Um, the fact is that we need to make paper copies of these forms available because it won't always be, even though of course increasingly we do things on computer, no one's disputing that. It will be necessary to make these available in hard copy. And to do that we'll need to distribute them out and get all of that right and in place. So in a sense that's we've got a bit of an operational focus on that because it's a big operation, but we'll want to set out in coming weeks how to be made available in the round, including those distribution arrangements and including how else it can be accessed.
Thank you. How will the actual new paper MCCD be distributed? Will it be who will be responsible for getting it to places like hospices and GP practices and things like that?
So this is the detail that we'll set out soon. I mean, essentially, at the moment, it's done through local registration services, and I suppose people already have these forms on hand in general, and when they need them, they can request a replenishment via the local registration services. What we're looking at doing is we're going to need to get new versions of the forms out into the system. So what we're doing is the logistics of basically doing a big mail out so that all organisations receive booklets of forms so that they will then be in the position of having them on hand, and then we'll also need a replenishment function so people can ring up. I think the details of how that's done will be different now. We're looking at the timings for basically which weeks in the coming months people will receive them, and when we've got that we'll tell people.
Thank you. Just to clarify, does the medical examiner who signs the MCCD have to be the same one who did the scrutiny? Because often this happens on different days, so it would be very difficult for it to be the same person.
I don't believe it does, no. The regulations are flexible on this. Alan may want to expand on this, but I think legally the answer is no.
Great, thank you. Will there be a transition period when both MCCDs, the old one and the new one, can be used, or will it be a sharp cutoff?
So we're expecting a cutoff rather than a sort of managed transition where either MCCD will do. What we'll need to be very clear on is, in addition to, of course, having those new forms in place, I think there are several things we'll need to have, put in place or be clear on. One is getting the new forms out so everyone can access them. Second is we'll need to be clear that these are from midnight when the statutory system commences, that you're using the new forms and not the old ones, and then need to be a process for withdrawing the old forms. And then we'll need to be very clear around there will be deaths that are in the process of being certified that occurred before midnight, as it were, so in the days before the statutory system, and those will be in the process of being completed, and those will be captured by the legal framework that's in place now. And for deaths that occur after the new regulations come into force, those will be covered by the new MCCD, but clearly we'll need to be crystal clear about all of this.
Thank you. There are a lot of questions about the actual practicalities of medical examiners signing MCCDs. Many medical examiners work remotely or on multiple sites. How do you think they will physically be able to sign a piece of paper? They won't necessarily have access to scanners at home and be able to print and scan and email round. Will it be possible to send some sort of electronic declaration that they agree rather than physically signing a piece of paper?
Yes, it will.
Great, thank
So
you.
this may not be completely clear from the regulations, which list the various components of the MCCD and include fields for the medical examiner and include a declaration. But the way to make this work in a way that's most straightforward for people is to allow the declaration to be done alongside the form, rather than the form being completed by hand. But we will set out again more about how that's done. I mean, there clearly there are quite a few questions around the practicalities of the paper, how it can be electronically transmitted, and then the sort of the kind of wider versions that will be available, that we're going to need to bring together for people so that it's clear how to do it. And of course, we're working with Alan to make sure that what we end up with is something that will actually work in practice for people in a variety of situations.
Thank you. And I believe you said it, but please could you just finally confirm that when the digitized MCCD is available, that should be the default method used, and that the paper system will only be for backup? Is that correct?
Yeah, so I mean, we will be launching, it will be legally perfectly fine to complete the paper form. As I've said, that doesn't necessarily mean filling it all in by hand and then couriering it for the next person in the chain to do by hand. And we can all think of what the most cumbersome version of the process will be, and that will be acceptable in law, but it probably won't be the way that we would encourage people to work, or that people would want to work. There will be I've talked about working towards a PDF, and also about in the longer term having something that's more of a web-based interface. When those are available, they'll be made available because they work and because they're more convenient for people, and you would therefore expect people to want to use them. But it will legally still be acceptable to use the paper forms, which need to be available, as a backup in any event.
Great, thank you very much. Thanks, David. We're going to move on now to the medical examiner MCCD, which is obviously a completely new certificate. And for that, we're going to hear from Dr. Jason Shannon, who's the lead medical examiner for Wales. Jason.
Thank you, Susie. Hopefully you can hear me. And a bit like Alan, I will try and just share a couple of slides to give it some structure. Bear with me.
Great, we can see those. Thank you.
Brilliant. Thanks, Susie. So as we're hearing today, many of the challenges set out in the secondary legislation are aimed at simplifying and facilitating accurate death certification. So let's consider how an MCCD issued by a medical examiner will fit with the wider aims set out in the plain English document describing the reforms to death certification. Whilst deaths can be registered now without an MCCD, so-called uncertified deaths, it's undoubtedly so that this arrangement is less than satisfactory, with an absence of a reliable death certificate leading to a number of potential problems. Firstly, it leaves the bereaved without a certificate stating the cause of death of their loved one. It leaves a gap in the national statistics, purely because of the tight legal processes that would prevent certification. And it can also, further down the line, lead to unnecessary post-mortem examinations with consequent delays to funeral plans and associated stress for bereaved families. In a recent publication, the Chief Coroner has described the link between coroner referral rates and the restricted availability of certifying doctors, particularly in community settings following the pandemic. We've already heard about the changes to death certification by widening the pool of attending doctors to try and reduce the delays and the number of uncertified deaths. Despite this, it is likely there will still be a small number of deaths in England and Wales where there is no attending practitioner or no available practitioner within a reasonable time frame. Defining a reasonable time frame is difficult, but it's not hard to imagine that the absence of an attending doctor for more than several days, and certainly for a week or more, would be considered by most as fitting the description of unavailable. We should remember that once the digital MCCD is in place, this may assist with the availability to certify. For a proportion of these deaths, there will be sufficient information available through a variety of other sources for an opinion as to the cause of death to be formed with a reasonable degree of certainty and accuracy. The question is who could certify those deaths reliably. For this reason, in line with the framework set out in the Coroners and Justice Act, there is an allowance for death certification to be completed by a medical examiner. The concept of a non-attending doctor certifying death is not new, at least in terms of what we saw widely in the pandemic. But to be clear, this proposed arrangement differs significantly from those in place during the coronavirus easements. A death brought to the attention of a senior coroner by a referring medical practitioner and then considered by the senior coroner as likely to be natural and not for investigation, would be referred to the medical examiner for consideration of certification using the medical examiner MCCD or ME MCCD. Unlike the non-attending doctor's certificate arrangements we saw during the pandemic, these proposals are more robust in that, firstly, by definition, the senior coroner is involved, and secondly, other processes of scrutiny will remain in place, in particular the continued interface with the bereaved, in exactly the same way as the medical examiner scrutiny processes for MCCDs completed by attending doctors. The bereaved will still be able to raise any issues they may have and ask questions about the death and the care of their loved one received. A proportionate review of the relevant clinical records will continue and form the foundation, although not exclusively, for the opinion as to the cause of death. The certifying medical practitioner will certify on the same basis, in other words, to the best of their knowledge and belief. The medical examiner will retain the option to examine or arrange for an examination of the body in reaching their opinion, should they wish to do so. It is unlikely that this will be necessary, as Alan has already mentioned, even for the vast majority of this small subset of deaths. Medical examiners should also work closely with their medical examiner officer and ME colleagues to avoid isolated working and spurious decision-making. The statutory notification of deaths regulations remain in place. In other words, where the medical examiner, on invitation from the coroner to consider certifying, determines that the notification of deaths regulations apply, including where the cause of death is unknown, the matter will be referred back to the coroner, thus preserving compliance with those regulations. An unknown cause of death is one of the categories for coroner investigation. Medical examiners play an important role in the determination of such a death. The step most likely to be absent is the interaction with another doctor. If there is another doctor who was in attendance, the default position should be that it is they, through their medical attendance, propose a cause of death and issue an MCCD for scrutiny by the medical examiner in the usual way. The ME MCCD should not be used as a means of certifying when there is an attending doctor who, for example, takes a view that the cause of death is unknown. In short, where there is an attending doctor, there should be an attending practitioner certificate. Alan has already stressed the importance of communication and good working relationships between medical examiners and coroners that will be critical in underpinning each and every case. Monitoring of this will be important, and given that such requests are by definition instigated by a senior coroner, it is likely to be done by coroner area, and being an exceptional arrangement, there should be close consideration of how it is being used. This is a new function for medical examiners that we didn't envisage at the beginning, and there are potentially resource implications should it become an onerous function. In summary, the proposal for the medical examiner MCCD provides an additional last resort mechanism for ensuring accurate and reliable death certification, where the normal means to do so via an attending doctor has been exhausted. All of the other steps remain in place to maintain the value of the scrutiny process to ensure that the deaths of these individuals are managed properly, thus maintaining the benefits of the medical examiner system for bereaved families and wider society. Diolch yn fawr iawn i chi i gyd, happy to take questions.
Thank you, Jason. One day I'm going to answer you in Welsh, but not today.
Not that I necessarily understand.
Thank you. So yeah, this is something new that we weren't anticipating. Just having a look at the questions. Could the medical examiner MCCD be used in circumstances where there's pressure of time, for example, a faith death over the weekend?
Well, I suppose, in truth, if there's no available doctor, it might start a process running. But we have to remember that it's the senior coroner that will be asking the medical examiner to consider certifying. So it all depends, I suppose, on the definition of reasonable. And if we are a service that puts the bereaved at the heart of it, reasonable is different for different families, isn't it? So I suspect this is something that might be tested in future, and we haven't yet defined what reasonable is for every single case. But where there is no attending doctor and it's in the interests for a certificate to be completed, then I don't see anything in the legislation that would prevent it. But I would just re-stress that this is an issue that will be driven in the first instance by the senior coroner.
Yeah, so there's no way that a medical examiner could issue a certificate without senior coroner involvement.
Correct.
Great, thank you. Some people saying their current coroner is not available at weekend. That will all vary with local coroners. Who will notify the senior coroner of the death if there's no obvious attending medical practitioner?
Yeah, so it may well be that it's quite likely in many cases that a doctor who is aware of the death but knows that they can't meet the criteria becomes, if you like, what is described as the notifying practitioner. And this is described in a number of the documents relating to the statutory notification of deaths regulations. So often they will notify, and in doing so say that I'm not an attending doctor. And I think a lot of deaths will come through that way. But giving it some thought, I think that there will be other deaths as well that the coroner will have the coroner will be notified of, or the coroner will become aware of, and may then be unable to, through the normal processes, be able to identify any available doctor to certify that death. And I can imagine that the process would continue in the same way, that the senior coroner has notified the medical examiner, I think this death is very likely to be natural, and I confirm that there is no attending doctor or one available within a reasonable time frame.
Thank you. Just having a look through the questions, many of which are not quite relevant to this particular talk. Would this be applicable for police referrals to the coroner as well, rather than just hospital or GP ones?
I'm not sure that it sets out specifically that it would have to be only in a case where a medical practitioner has notified a coroner. The key thing I see in the legislation, it's the senior coroner's determination that this death is likely to be natural and one that they are not going to investigate. The difficulty with police referrals is that they could occur in all sorts of circumstances, and there may be many of those types of deaths for which it would be obviously completely inappropriate for a medical examiner to be asked to certify.
Thank you. And I think we've already covered some of this next question, which is about, we don't want medical examiners to have the duty to refer cases to the coroner, but are they able to refer these cases to the coroner if there's no obvious attending or non-attending doctor to who will do it?
Well, it's interesting. If you look at the notification regulations, it doesn't actually specify that the attending practitioner is by definition always the notifying practitioner. Notification regulations make it very clear that it's the registered medical practitioner. And I think if we think about it, that's a really useful, the best way of understanding that is it's a good safeguard against an attending doctor who decided never to refer a death to the coroner, that at least a medical examiner through scrutiny would have that duty placed upon them. So I think it's important to recognise the statutory notification regulations apply to all doctors who are, once they become aware that that the regulations apply in that case. But I think it's unfortunate, isn't it, if medical examiners had to refer lots of deaths to coroners because they weren't being referred by other people who knew further up the chain that they needed to do so.
Thank you. There's a lot of questions about attended, and many of them say, does video count? Does telephone count? What counts as attending? And just to say that this will all be covered in the guidance, and we can't just answer that on the spot today. Just a question about the formal mechanism. How do we know that a request for a medical examiner MCCD has come from a senior coroner rather than the coroner's officer team?
Yeah, I think a lot of local knowledge is clearly going to be important. As it is now, the working relationship between medical examiners and coroners is such that the familiarity is really, really important. So it's going to be something that would need to be agreed as a mechanism. I've not seen any formal documentation that says this is the notification document from a senior coroner to a medical examiner. Not that one won't necessarily be developed, but it would be important for the medical examiner to establish with certainty that that notification is bona fide and has come from the senior coroner in their area.
Thank you. I think that is most of the questions that relate specifically to the medical examiner MCCD. I'm just trying to whiz through them. It's very difficult keeping an eye on every single question. I'm trying to answer as many as I can during the talks so that you're getting answers. But as I say, we will review all of the questions and we will cross-check those against the guidance to make sure that the questions that are being asked will be answered in the guidance.
Susie, whilst just carrying on looking and you can't
Yep.
see anything immediately for me, just on the issue of attendance, I think it's a bit like, I often describe it's a bit like obesity. It's easy to recognise but hard to define. And attendance suggests some kind of either history taking or examination or some kind of tangible clinical input into that patient's management. I no doubt there are grey areas, but I think in most cases, the recognition of what clinical attendance means should be relatively straightforward to recognise. But I do appreciate there will be cases where people will say, does this constitute attendance?
Great, thank you very much. There's lots of questions about who can actually refer to the coroner. And of course, anyone can refer a death to the coroner. So people saying, could it be an allied health professional rather than a GP? Yes, absolutely.
Next door neighbour can refer to the coroner. It is a statutory duty for doctors to do so, but nobody is prevented from referring a death to the coroner. And that's why, of course, a non-attending medical practitioner could equally do so, but they would also be compelled by the statutory notification regulations.
Yeah, thank you. And not quite related to your talk, but a couple of questions about, in their system, the coroner requires the medical examiner to do all referrals to the coroner, and they have to go through from the medical examiner. And is that permitted? And again, it is permitted, but you might want to review how much extra work that is requiring of your medical examiner service, because it's not a core part of your job.
Yes, and the guidance I've seen is I think the phrase is it's normally expected that the notifying practitioner would refer the death to the coroner. I think Alan already touched upon it, that it was because of, by and large, their attendance becomes, they know the patient, I think was the phrase that Alan used in consideration of that point.
There's a question about where does the cause of death come from for these cases? Does the coroner suggest it to the medical examiner, or does the medical examiner suggest it to the coroner when the case is referred in?
That's a really good question. I think many coroners I've spoken to would regard that it isn't for them to be suggesting a medical cause of death because they aren't medical. Indeed, it works the other way round, that in their investigative processes, they will require an opinion as to the medical cause of death. So for the medical examiner, it's through a review of the records and any other means by which they need to enhance their knowledge and belief basis for giving an opinion as to the cause of death, which may rarely include suggesting an examination of the body, but the interaction with the bereaved will be really important, and any other individuals that they may feel have useful information that can help them in forming that opinion.
Thank you. And it very clearly says senior coroner throughout
It
the
doesn't.
guidance. Does that mean that no other coroner within the team is allowed to be involved in this?
Well, everything I've seen indicates the senior coroner. I suppose the only issue is what happens when the senior coroner is away. My understanding is, and the coroners perhaps could clarify this, but somebody steps into that role when they are away, in a sort of legal sense, usually an area coroner. But I'll leave that to coroner colleagues to consider. But yes, my understanding is it wouldn't be just any of the coroners, it would be the senior coroner.
Thank you. And our first talk after the break is about the coronial process, so we can explore that a little bit more now. Then, thank you, Jason, very much, and thank you all for the a very information-packed first half of today, and thank you for all of your questions. I'll continue to try and answer as many as I can during the break. A lot of them will be answered in the talks after the break, so hopefully you will get the answers you need. There's a question about the guidance and when will it be available, and obviously the answer to that is as soon as possible. But as you heard earlier, the closing date for feedback on the draft regulations was only last week, so all of that is being worked through, and all of this, I mean, today forms part of the information gathering process, and seeing your questions is enormously helpful and will help make sure that the guidance is as comprehensive as possible. We'll now have a 20-minute break. We'll see you back here. There'll be a countdown clock on the screen. See you back here at 11:50. Thank you. Welcome back, everybody. We move into the second half of the meeting, and the first talk is about changes to the coronial process, which I hope will answer many of the questions that have come up in the chat. If there are questions in there that relate to this morning's talk, so we won't get an opportunity to come back to them today, I'm going to remove them from the list so that it makes it easier for me to see the current questions so that I can put those to the speakers. So please don't be alarmed if your earlier question disappears. If I've misjudged it and you feel it needs to be asked again, you're welcome to retype it, but I'll remove anything that has already been answered or refers to the morning. So I'd like to introduce both James Parker from the Chief Coroner's Office and Heather Atkinson from the Ministry of Justice, who are going to give us an overview of changes to the coronial process. Thank you.
Morning. Thanks very much, Susie. You've got a bit of a double act for this next session, obviously, between James and myself. I'm Heather Atkinson from the Coroner Policy Team at the Ministry of Justice. James, as you'll know, is head of the Chief Coroner's Office. I thought it might be helpful to just kick off with a brief explanation as to why you get both of us and what our respective roles are in this process. The MOJ team, broadly speaking, is responsible for law and policy around coroner services. James's team, in effect, although not in statute, leads on operational aspects of coroner services, supporting local coroner areas in their operations through the Chief Coroner's role as a leadership judge. He may want to say a few more words about that. So you've got us both, me from the policy and legal aspect, James from the more on the ground point of view. Clearly, what we're talking about today is a bit of both. It's all enshrined in legislation, but is essentially an operational change, the introduction of a new operational process. And so for that reason, I'm going to hand over to James in a few minutes to talk about the impacts on the ground and how we've tried to anticipate and cater for those in the regulatory framework. But it's worth saying, I mean, it's evident from the very purpose of today's webinar that none of this is linear. Everything is linked. Even within MOJ, things we're thinking about in relation to coroners have an impact on cremation, for example, as has already been alluded to this morning. And so everything we're hearing in all of these sessions is really valuable to all of us in understanding the real practical on-the-ground detail of the journey we're about to embark on. So with that in mind, James, shall I hand over to you to talk a little bit about the way we've approached the changes from the coroner's point of view? Thanks.
Thank you, Heather. I'm James Parker, as Heather said. I'm head of the Chief Coroner's Office. I support the Chief Coroner, who's His Honour Judge Tommy Teague, KC. And as you'll all know, his role is primarily as the judicial leader of coroners, of all coroners in England and Wales. He has certain statutory functions, but he has a lot of functions which are not really purely statutory. And obviously we have a local system of coroners in England and Wales. There are 80 coroner areas. And there's no national service, so Chief Coroner is not a chief executive of a service. But obviously in situations like this where there's new policy, where we're developing and working with MOJ and coroners and other parts of government on impacts, and we have a important role in making sure that policy implementation at an operation level can work, and that's why we're here today to talk about it. So I wanted to run through, if it's okay, and Heather will chip in at various points, I think, the major changes. I say changes advisedly because I want to make one point first, but the major changes that affect how the effect on the coroner system of the statutory medical examiner system. The first thing I want to do is just really important that we all, I think, emphasize the continuities as well as the changes. So obviously, one continuity is we already have a non-statutory medical examiner system in many settings, in many parts of the country. I mean, in terms of acute care, it's very, very widely rolled out across England and Wales. And the other continuity is we are basically, the death certification process is not changing, really. We're still having the basic overview of the system is some deaths reported to coroners, some deaths of natural cause being a doctor issues a medical certificate. What's changing in that process, and then the medical certificate is sent to the registrar for registration, and then burial or cremation can take place. What's adding into that process, obviously, is the medical examiner as a scrutineer of the MCCD. That's how I see it. And so I think it's really important to emphasize the continuity, because, in particular, because the we have to gear up, and we're gearing up for the statutory system. But there are. It's not like we have no medical examiner offices. Coroners work with medical examiners all the time across the country. So there are changes, however, and I think it's important to be really clear about what they are. So for coroners, the main effect of the regulations and the statutory scheme will be felt at the start of the process, what I would call the start of the process. So from the point of view of the coroner, that's the report of death to them. And the main change for coroners is that, and you'll hear from registration in a bit, and I'm not sort of want to cut across anything they've got to say, but for coroners, what the big change is actually is that the registrar will no longer need a form, what we call a Form 100A, which is a non-statutory form from the coroner to accompany an MCCD, and that will be in a case. What happens now? An MCCD is issued if that death's reported to the coroner, but the coroner decides that their duty to investigate under Section 1 of the Coroners and Justice Act is not engaged, and that's a judicial decision by them. The Form 100A accompanies the MCCD, and the registrar needs the 100A with the MCCD to register. That's going. That requirement is going. So as a result, we have to make changes with MOJ to that side of the process. So there will be a replacement for Form 100A. MOJ are working very hard with my team, with the coroner software providers and others to get that into place before implementation. That the purpose of that new form will be the main purpose will be for a record of the coroner's decision, their judicial decision, that their duty to investigate the death does not arise. From there, it's actually really the process as it is now. If their duty to investigate doesn't arise, it's then in the hands of the, if there is one, attending practitioner to go through the normal process with scrutiny from the medical examiner. So I mean, in the broadest sense, that is the change. I think it's probably quite important to talk about the other routes at that point, the other routes through which deaths can be reported to coroners. It's not only through an attending practitioner, as we've heard. It can be from a practitioner who's not attending, and as you know, the notification of death regulations don't talk in terms of attending practitioners having an obligation. It's on a medical practitioner. Many deaths are reported to coroners by the police because they attend deaths in the community, and with reports of death come to coroners from others. With police deaths, fundamentally the process doesn't change. Now, if a police officer reports a death to the coroner, and the coroner says, my duty to investigate is not engaged, that death has to be registered and there has to be a medical certificate for that death. And if there is an attending practitioner who can be found to certify that death, that is what happens now. So fundamentally, that side of things doesn't change. What actually is advantageous is in those rare and unusual situations, and I think those situations will become increasingly rare because of the liberalisation of the criteria for who can be an attending practitioner. What you've already heard, there is a scope capacity for the medical examiner to issue their own certificate in those situations, which I mean, from our point of view, we think will be rare now, where there is no attending practitioner, but the coroner decides judicially they do not have a duty to investigate. And that's what that process in the regulations is designed to cater for, because we all working together in the system want to avoid uncertified deaths or unregisterable deaths, I suppose. There will be guidance from the chief coroner in due course. The timing of that guidance, as Susie said, in terms of other guidance, will be as soon as possible, but it does depend on a number of things starting into place. And we talk all the time to participants in the system. The chief coroner meets with the national medical examiner on a regular basis, and our intention always will be that our guidance to coroners interlocks in terms of content with where it's appropriate to do so with other guidance from other parts of the system. There's a couple of points already that were raised in questions, and I just wanted to pick in particular one of those up. The term senior coroner is a technical legal term in the 2009 Act. So the question was, who can refer a death under the regulations? It only talks in terms of the regulations, draft regulations only talk in terms of senior coroner. In fact, in real practical terms, it is any coroner who's able to exercise the jurisdiction in that coroner area is able to exercise the powers or fulfill the duties, or however you want to describe it, in the regulations. The term senior coroner is in the 2009 Act, but for technical reasons, it basically means any coroner. So it's not only the senior coroner who will be able to refer cases to the medical examiner or do whatever flow needs to happen in the regulations. So I hope that's clear. And I think that's everything on my list to talk about. But we've got time, obviously, for questions, and so back over to you, Susie, unless Heather, there's anything you want to add.
Thank you. So a couple of the questions that have come up, I think you've already answered. And just to clarify those, so when the Form 100A goes, it will be replaced by something else. So there will be some written communication that goes back to the medical examiner office, so they have a record of that decision. That's correct, isn't it?
Well, yes. I think the flow technically in the regulations is that there's not a statutory requirement on the coroner to give that information to the medical examiner. The baton, as I would describe it, goes back, as my understanding, goes back to the attending practitioner. But yes, there will be a form which records the the coroner's decision, and that will be available in this, that decision, of visibility of that decision will be available in the system. So yes, to answer your question without being too technical about it, Susie, yes.
Great, thank you. And thank you for that clarification about the senior coroner thing, because I think there was some worry that it wouldn't be any other coroner, but it's helpful to know that it would be. Thank you. There's a question about in deaths in the community, for example, in the evenings, the weekends, bank holidays, if they're reported to the coroner via the police, is the expectation that coroners should refer these deaths to the medical examiner service to establish if an MCCD can be issued and for the medical examiner review to be conducted? Or should the coroner service carry out their initial inquiries first and then refer to the ME only once it's been established that a post-mortem is not required and the MCCD can be issued?
I mean, my understanding is it's the latter, and this is why I want to emphasise the continuities. So that is what coroners do now, not leaving aside the question of the ME. They get a report of death and decide about whether they have jurisdiction, because if the law requires them, if they've had a report of death, to decide whether their duty to investigate applies. So my understanding is that is what should happen. And I need to emphasise again, there is no. There's a lot we can fill in guidance about good practice and good communication, but there's no statutory requirement in the regulations for coroners to provide a referral to the medical examiner. That's, I mean, unless anyone wants to tell me anything different, but that is what the regulations say. So that's not, of course, to say there shouldn't be. It's not, and as Alan has emphasised, there shouldn't be. It's paramount. There should be really good communication and ongoing sort of dialogue and agreed working practices between local coroners and local medical examiners. But to sort of be too technical, very technical about it, that's my answer. But yes, I mean, the coroner should decide whether their duty to investigate is engaged, because I think they have an obligation to do that.
Thank you. Do you know if there'll be any further guidance about standardisation of how coroners interact with medical examiners? Because we know at the moment that there are very different practices, with some coroners, for example, insisting that all referrals are triaged by the medical examiner first before they go to them, and others accepting referrals directly from the attending doctor.
Yes, there'll be guidance from the chief coroner, and it will deal with as much as possible that there should be consistency of practice, and that consistency of practice should be consistent with the regulations.
Thank you. Just looking at all of my questions coming in. Yeah, somebody saying in their area, senior coroners insist all deaths go through the ME service. So that's something that does happen in places. Are there any plans for obviously natural deaths that are attended by the police to be referred by the police directly to the medical examiner rather than to the coroner as they currently do? Because then it just cuts out the coroner having to ask the ME to investigate.
I don't think I can answer that question, because that's really a policy question, I think, for others. We're not working on the assumption that is being put in place at the moment, but I don't want to say things that are not consistent with things that others are thinking about in the system.
Thank you, understood. Can the referral for a medical examiner MCCD, which we've heard about from Jason, can that be delegated from the senior coroner to the coroner's officers, or must it come directly from the senior coroner?
So I think that's a slight. I would say that's a slight distinct. That's a distinction that I don't think is. Well, sorry. Let me start again. Coroners' officers communicate the decisions of coroners, so they act as the people who communicate the decisions of coroners. So if obviously, like all staff who are fulfilling transmitting or acting on behalf of judicial office holders, they shouldn't be making decisions that are for the coroner. But if the coroner has said, in all the circumstances, I think this is a death that should be referred to the ME under the provisions in the regulations, if a coroner's officer is doing that on behalf of a coroner, that is entirely appropriate.
Thank you. This question, which you may not be able to answer, but I think I know the answer to. So if a death is referred to the coroner, and then whatever new form it is that replaces the 100A is issued, Does the medical examiner then have to scrutinise the death, or does that count as the death having been scrutinised by a coroner?
Do you want to answer, Susie? I think I know. I mean, as far as the regulations provide for, I'm pretty clear about the answer, but it is that, sorry, the latter. In that it's not the statutory responsibility in that situation where there is the coroner's duty to investigate is not engaged. The coroner is not under a statutory obligation to determine judicially the cause of death. So the ME must scrutinise the cause of death that is proposed from the MCCD, because there must be an MCCD in that situation for the death to be registered.
Yeah, I agree. I think,
right, great.
I think if people are wondering, I mean, I know you can't always do this with legislation, but if you're thinking about the whole purpose of the medical examiner service, it's about assuring the people signing the certificate that the cause of death is correct and that concerns have been taken into account, and therefore the ME process needs to be followed. And of course, the attending doctor and the medical examiner will be signing the MCCD in their professional capacity, so they need to be assured that that scrutiny has taken place.
I mean, it's worth saying is generally, you know, anytime you look at some regulations which describe a flow in a system, they are necessarily quite Spartan, and they don't really reflect the rich sort of variety of how things work on the ground. So, you know, there's always dialogue and there's always exchange of information in the system. But yes, I mean, you're exactly right.
Thank you. Just keep an eye on time. We've still got a couple of minutes. Just going through the questions. Okay, I think I've asked you most of the questions that are appropriate for you to try to answer. If there's any others, obviously we'll pass them on to you afterwards. So thank you both very much for those, and we'll move on to the next talk. And if there's anything that comes up later, we'll let you know. So thank you very much for those. We're now going to move on to the section on death registration, and I know there've already been a lot of questions about this already because there's quite a few changes that are coming up. So I'd like to welcome Eric Powell, Head of Registration Services at the General Register Office, to speak to us. Thank you, Eric.
Thank you, Susie. Thank you for the introduction. Good afternoon, all. So there are a number of changes to the registration process, which I think in many respects they simplify the role of registrars in this area. So I'll just run through the core changes, and then we'll take any questions. So I think firstly, one of the key changes is that deaths will not be registered until the registrar receives notification of a cause of death from a medical examiner or the coroner. This notification starts a 5-day statutory timeframe for informants to register a death. I know it was one of the questions earlier was around whether there's any provision for bank holidays or weekends. There isn't. Just picking up on the point Alan made earlier, I think we all need to consider that the bereaved are at the heart of this process, and all parts of the process and individuals involved need to do what they can to expedite all parts of the process as quickly as possible. Okay. Secondly, because informants should have the opportunity to discuss and be aware of the cause of death before registration, there should be reduced instances of concerns being raised with registrars. If any are, then the registrar will refer back to the ME or the coroner accordingly. It's number 2. Number 3, there will be no requirement for registrars to refer deaths to the coroner, which is a significant change from the current position. I know that's been mentioned by others previously. Mentioned by David, so just to confirm, the Registrar General and registrars will no longer have responsibility for providing MCCDs. That responsibility moves to the Department of Health and Social Care. And as David indicated, there is a logistical exercise that needs to be undertaken to make sure that those forms are available to all in time for reforms. And as James has just mentioned, Given the limited interaction between registrar and coroner, the need for Form 100A is removed. So that form will no longer exist. More registration changes. So we're taking the opportunity to introduce new categories of qualified informants who can register deaths. This is a particular bone of contention with many members of the public currently who aren't able to register the deaths of their loved ones. So it will provide for qualified informants to be the partner of the deceased or a representative of the deceased as well. We are introducing a short death certificate should informants wish to have access to that. Effectively, it contains very similar information to the long death certificate, the normal death certificate, but not including cause of death, which for a variety of reasons, informants sometimes do not wish to disclose to those that they share certificates with. We're also introducing a change where registration over 12 months following the date of death no longer requires authorization of the Registrar General. So the registrars will be able to do that. Not directly related to the death certification reforms, but at the same time as implementation, we will also be implementing provisions that are in the Judicial Review and Courts Act 2022, which are intending to reduce the number of unregistered deaths, which is a problem. There's about 200 deaths across England and Wales currently go unregistered. All where a coroner discontinues an investigation without inquest and issues a form for registration. So the intention would be that if registrars are unable to get an informant to subsequently register the death, there would be engagement between a registrar and the coroner in order that the coroner can give the registrar sufficient information for that death to be registered. It's a bit of a backstop. The registrars will still seek to get informants to register deaths, but if they're unable to, the coroner will be able to assist them with that. There was questions earlier around how a registrar is being engaged. We work very extensively with a wide range of groups and bodies within the registration service. This afternoon, for instance, we're meeting with the National Panel for Registration, which represents registrars, and we will be talking in detail with them about the reforms. And we'll be updating guidance systems and developing training material accordingly. Just to echo something that Alan said earlier, and I know other speakers have mentioned, one of the critical things that will support the success of these reforms is that at a local level, those main participants, MEs, registrars, coroners, have really good engagement, that triangle that Alan mentioned earlier. It's critical for all parts of reforms that those relationships are strong and frequent. I think that's all, Susie, by way of the core changes in relation to registrars and the registration service. So just any questions, really?
Great, thank you. Just a couple of questions that have come in. Just to clarify, does this mean there will no longer be any uncertified deaths, all the things we've heard about so far? Does that mean they'll go completely?
That is the aim, Susie. There has been increasing numbers in recent years, and it is problematic. So the intention is through this new process that there will be none or very, very few uncertified deaths.
Thank you. There was also a question about the number of uncertified deaths that there are. You've mentioned they've increased recently. Roughly what proportion of deaths are they?
So I don't necessarily want us to take the thunder from our ONS representative, who is going to be talking shortly, but they're in the order of 10,000 or so in the last 12 months. So a significant.
Thank you. Will there ever be a return to being able to register deaths over the phone, or will it continue to need to be in person?
Okay. So not directly linked to the death certification reforms. We have those provisions were in place under the Coronavirus Act. That act sunsetted, so we had to stop that provision. There is currently a bill before Parliament called the Data Protection Digital Information Bill, which provides us with the primary legislative powers to be able to allow for remote registration again. So that bill currently progressing through Parliament, expected to get royal assent sometime before summer recess. We will then be working on when we can commence those provisions so we can bring back things like death registration, and in due course look for the ability to be able to provide digital registration as well.
Thank you. A couple of linked questions now. So at the moment, we all have the cause of death list and we can see deaths that are currently unacceptable. Will a death that is currently unacceptable, according to the cause of death list, become acceptable if signed off by an ME?
So registrars will not be instructed to inspect the cause of death list. They will take the ME's certified cause of death as what they should register. I think, as Alan mentioned earlier, only if there's any real something missing on the MCCD would we see that the registrar would need to query with the MA.
It is possibly not one for you to answer, but I'd be interested in your opinion. Do you therefore think there's any need for an updated cause of death list?
I think from a registration, from a GRO perspective, I think our views are agnostic on that. I think it's more for if it's required for supporting medical professionals rather than registrars.
Yeah, and perhaps one for Johnny in a minute in terms of statistics, if we start changing causes of death. Thank you. How will the registrar contact the medical examiner office? Will it be phone or will it be email? So we've got a paper trail.
So I think that will be down to local arrangements. There are already local arrangements in place, aren't there? So we're just moving from the non-statutory scheme to the statutory scheme. So I would expect whatever the local arrangements are in place, they'll just be built onto the statutory scheme.
Thank you. There's lots of questions here about the cause of death list and people saying, oh, can I write renal failure? Can I write frailty of old age for somebody who's 25 and so on? The answer is, well, I mean, Eric could answer this, but from a registration point of view, as Eric has said, the registrar will not be checking the cause of death. However, the medical examiner will. So the medical examiner still understands the concepts of how to formulate a cause of death correctly, and it's expected that that will continue to happen. So if you write renal failure, the medical examiner will want to know what's the underlying cause. And if you try to put frailty of old age for somebody who's 25 or 65, the medical examiner will want to explore that in more detail to make sure that the cause of death is as accurate as possible.
Agreed, Susie. As I mentioned earlier, in many respects, I think this simplifies the role of the registrar in the process, that they don't have to concern themselves as much with that sort of thing as they currently do.
Thank you. Just reading the questions. Okay, question about cremation. So we've got a talk coming up on that a little bit later. If a bereaved family raise new concerns when registering the death, or they mention perhaps possible occupational link to the cause of death, what would the registrar do then?
They would refer them back to the ME or to the coroner as appropriate.
Yeah, thank you. Are there any circumstances in which the registrar would go straight to the coroner rather than back to the medical examiner? Would that only be for cases that had come to them from the coroner, or would it be up to the registrar to decide the best route to send them back?
No, the intention is a registrar that just goes back to the same, goes to the route. So if it's from the ME, they'll go back to the ME. If it's from the coroner, they'll go back to the coroner. There shouldn't be a circumstance where something comes from the ME and the registrar goes to the coroner.
Thank you. That's very helpful. Again, lots of questions about the cause of death list. As the author of the list, I would say I feel very strongly that this list should be updated. It was last published, I think, 2019 or 2020. The intention had been that it would be updated last year. That was delayed pending the new regulations. It will not strictly be required in that we won't need a list that both registrars and attending doctors will need to consult and compare. However, there is still a need to ensure that causes of death are as accurate as possible. So I think we need a new cause of death list, and that's something that we can look at once we've got past all the work involved in this. So yes, in answer to all of those questions, the intention at the moment is that there will be an updated cause of death list, but it won't be ready in April. It will be something that I'll start work on once we've got past the introduction of the statutory system. It's a question about clarifying the 5-day rule and concerns about that. And I know you can't answer all of them, but if the clock doesn't start ticking until the MCCD has been provided, what guidance is there going to be on how long the gap should be between death and issuing of the MCCD? Is there any reason why that can't be a month or 6 months, for example?
So I think Alan covered that earlier. That is covered in the ME guidance, and it's also covered in the regulations. There isn't a specific 1 day or 2 day time limit. It's about expediting the process as quickly as possible. And as I've said now, as Alan said, bereaved are at the heart of this process. So we certainly should not be causing any undue delays to the process.
Thank you. I'm just scanning the questions to see if there are any new ones. Okay, I think that's most of the ones relating to registration. Eric, thank you very much for those. We'll now move over to Johnny Tinsley, Head of Health Data from the Office for National Statistics, to talk about mortality statistics, which are obviously closely linked to registration of death. Johnny, thank you.
Great, thanks, Susie. Can I just check you can hear me okay?
Yes, absolutely fine, thank you.
Excellent, thank you. Yeah, so thank you. I don't have long for my section, so briefly, ONS has a statutory responsibility to produce births and mortality statistics annually. But in addition to that, we also produce a whole host of other mortality statistics. And there is it's the legislative ability for GRO to transfer the data to us for that purpose. You'll be aware of some of what we do, probably because of the pandemic. So as well as annual mortality statistics, we also produce weekly mortality statistics, which were very important early on in the pandemic and were in the news quite a bit. Probably the single biggest thing we do is convert the cause of death text into ICD codes, so International Classification of Disease codes. At the moment, that's version 10. And the World Health Organization have now released version 11, which we will be transitioning to at some point. The biggest change from our point of view is relatively straightforward in the sense we just need to change our digital systems really to be able to cope with some of the new fields that are appearing. So in the cause of death text itself, there will be the addition of line 1D. There will also be the addition of a pregnancy indicator. Those two bring us closer in line internationally with what the World Health Organization would suggest a medical certificate of cause of death should look like. And in addition, there'll also be the ethnicity field as well. But a lot of what else has been talked about today is relevant to us. So uncertified deaths, for example, as Eric noted, they have been increasing. They used to be about 2,000 a year. In 2022, it was 8,000, and then last year, more like 14,000. So going from less than 0.5% to kind of more like 2.5–3%. And although the cause information might be there, there's maybe less assurance about how accurate and the quality of that for statistical purposes. So it's certainly something we're keen to see is the mechanism introduced to mean that we kind of move away from having uncertified deaths if at all possible. There is also guidance for medical practitioners to complete the medical certificate of cause of death, which we used to own. DHSC will now own that, but we'll work closely with them to help guide attending practitioners and medical examiners on the best way to complete it. Obviously, it's already the case that for what is essentially the same condition or disease, so it would end up with the same ICD-10 code, it will already be recorded in lots of different ways by lots of practitioners. So one of the things we do is use our expert coders and also the automated software we use that's used by a number of nations to standardize that text and essentially make sure that what is in fact the same disease all gets classified as the same code, even though it's been recorded as different text. And I think that relates to the cause of death list that's been talked about, and also to the guidance I just mentioned. One other thing I could mention, given I've got the opportunity, is that, and this isn't really changing, but it's already the case that the MCCD has information on duration, and that is sparsely populated at the moment. And if at all possible, we'd like to see greater completion of the duration for each of the lines in section 1 of the MCCD, because the duration can affect which of the conditions that are noted on the MCCD actually become the underlying cause of death. So there's a lot of work we do internationally and with WHO to develop the software that helps change the text into ICD codes, and a part of that process also includes determining what the underlying cause of death is, and that helps with kind of data quality and therefore international comparability, as well as using the data ourselves to produce statistics. We also, once it's coded, also transmit it back to NHS England, NHS Wales, UK Health Statistics, Health Security Agency, sorry. And between all of us, we therefore produce analysis that will help decision making, that will support public health decisions and planning moving forwards. Hence the importance of as accurate data as possible. So with the guidance, we'll be working closely with DHSC and then also obviously the National Medical Examiner's Office, so Alan and team, to feedback on anything we think needs to go into the guidance to make sure that cause information in particular is being recorded as accurately as possible. For that reason, really, is that the best decisions possible can be made on our statistics, because we're confident that our statistics are as accurate as possible. Just briefly, because I think I've got time, one of the other things we'll be doing, as well as changing our digital systems, is looking at the impact of the introduction of medical examination in and of itself. So there was very little before 2019. There's obviously been an increasing proportion on a non-statutory basis between 2019 and now. And then from when everything goes live, it will be 100%. At the moment, we don't see in our data whether something has been scrutinised or not on a non-statutory basis, but it will be interesting whether the kind of there's been an artifactual change in patterns of cause of death purely because of the introduction of medical examination in terms of how certain causes are being recorded, which might be quite hard for us to tease out in the data, but we'll certainly see whether we can do it. And then the last thing to mention, I think, is about our perspective on registration delays. So for a lot of statistics and patterns in cause of death, it's obviously becomes apparent over the long term, but in certain cases the kind of short term patterns and statistics are important. Clearly with something like COVID and the pandemic, and also quite recently there's been a lot of interest in excess deaths that have been caused by the pandemic, where the weekly statistics are more important, and therefore the timeliness of the data is also important. And so the average registration delay has increased over the last sort of 2 or 3 years because of NHS pressures and other things. And so we would also, as you might expect, have an interest in making sure registration delays are as short as possible, which would be in line with making sure that the bereaved are getting the information and certification as quickly as possible, where obviously their interests and making sure that's achieved is far more important, but our interest is also aligned with that, and would have an interest in registration delays being minimised as much as possible. I think that's everything I wanted to cover. I'm happy to take any questions.
Thank you. I have a lot of questions, but I don't think we'll be able to ask them all. I think particularly as medical examiners, we spend a lot of time trying to ensure that the cause of death is as accurate as possible, but we never know quite what level of detail the ONS requires and whether it makes any difference. So some of the questions are, for example, does it matter if we say hospital-acquired or community-acquired pneumonia? Does it make any difference to your coding? Or could we just write pneumonia?
I don't know an immediate answer to that. We have expert coders at ONS who I would probably defer that question to. I suspect the answer is no, that it doesn't matter. But with these sorts of questions, if people want to log them today, we absolutely can make sure we include that in any guidance for the best completion of cause of death within the MCCD. As I say, that document already exists, and we will update it in collaboration with DHSC now that they're going to take ownership of it.
Thank you. And the obvious question that several people have asked is, if you're coding everything to ICD, wouldn't it make sense for us to use ICD codes on the MCCD, for example, and when it becomes digitized to have drop-down boxes where we can select them, so that it would ensure that the correct cause of death was being chosen and it would automatically code it for you?
So that has been considered. I think the main reason that we wouldn't do that is to ensure that we're not constraining the medical practitioner and leading them down any routes, sort of, for example, the list of codes that might come up when someone starts to type in a term and what's highest on that list, and making sure that the attending practitioner or the medical examiner has full flexibility to write what they think was the cause, and then leave that task of the conversion from the text into the codes to us, to make sure we're not biasing any of the statistics through an artifactual process that's been caused by the system, or constraining people to a list of codes and text, if that makes sense.
Thank you. Will it matter from a statistics point of view that the cause of death list essentially will not have the same function as it previously did, in that registrars will not be able to reject currently unacceptable causes of death in the new system? Will that matter in that you may start to receive previously unacceptable causes of death? Will that skew the data?
So I think this all comes down to our relationship and interaction with Alan and team, and the guidance that's provided to medical examiners about what is and isn't acceptable causes of death to end up on the MCCD. So the point of influence is just changing, I think, about where we ensure the quality of the cause information. If Alan disagrees with that, happy for him to chip in, but I think that's what we would do, is work closely with him and team, and obviously with Wales counterparts too.
Thank you. Something that comes up often at the medical examiner training is whether or not one should include things like smoking on the certificate. Is that recorded and helpful in any way?
Again, I would have to defer to the expert coders at ONS. Happy to take any questions of that nature, and the one I think you asked at the start away, and make sure they are part of any guidance that we issue.
Thank you. Yep, somebody suggesting perhaps it would be helpful to have a an update from ONS coders with medical examiners, so we have better understanding of what that means. And certainly the college is looking into holding regular webinars for medical examiners. So that's perhaps a topic that we could explore.
Yeah, that sounds like an excellent idea. Happy to do that.
Thank you. Just quickly scanning. Yes, as somebody's pointed out, if it's hospital acquired or community acquired or associated pneumonia, that should be on the MCCD. And I think particularly, even if it doesn't make any difference to the actual coding, going into detail about things like that, particularly if it's related to antimicrobial resistance in any way, and I refer medical examiners to the National Medical Examiners Good Practice Series document on that topic, that it is helpful to have as much information as possible, particularly for those organisms. Question about what gets coded by the ONS, and again, this may be a bit too specific. Is it what's in 1A or 1B or 1C, or do the coders look at the whole lot together and come to a conclusion?
Yes, so a lot of that is automated. As I say, there's and so all of it gets included. So there is room to record several ICD-10 codes, both from Part 1 and Part 2. And so if you think, for example, about our COVID statistics during the pandemic, there was statistics both on deaths due to COVID, i.e. it was the underlying cause, but also statistics on deaths involving COVID, because the ICD codes for COVID would be there if they were recorded anywhere on the MCCD. But then part of the coding process is then to decide what's the underlying cause. And then in our database, which we can analyze, we'll have the underlying cause and then any mentioned codes that are also relevant, both from Part 1 and Part 2. So it will all be fully coded, plus then an underlying cause.
Brilliant, thank you. We don't have any time for any more questions, but obviously I'll forward the ones that we have got to you for you to have a look afterwards. Thank you so much, Johnny. We're going to move on to our next talk. And I know there's been a lot of call for this. We've had lots of questions already about cremation and burial. And I know Laura has already received questions, particularly from crematorium medical referees. I'd like to introduce Laura Pankhurst from the Ministry of Justice, who will talk to us about cremation and burial. Thank you, Laura.
Thanks, Susie. Hi, everyone. I'm Laura Pankhurst. I'm Head of Disposals Policy at the Ministry of Justice and the lead for MOJ on all the work relating to medical examiners and death certification reform. I'm just checking that everyone can hear me because my screen's just gone black.
Yes, absolutely fine. And I can see you. Thank you.
No worries. Thank you. As you'll have heard repeatedly today, all of the work that we're doing in this space, it spans a number of departments and agencies and broader than that as well. From the perspective of my team, we work closely with stakeholders from the burial, cremation and funeral sector, and I know a number of those are on the call today. I'm conscious that we've been on this for a little while and you've had a lot of detail, so I'm going to try and keep this fairly short, and I'm going to just take you through the process as it relates to burials and cremation. We've done quite a range of engagement with our stakeholders already. So I've pulled together a list of the questions that we get most often, and I'm going to try and cover them off. And I've also been having a look at the chat, at the questions coming in. So I'm hoping I'll cover all of those off as I go through this, but if not, I'm sure Susie will jump in. So the main questions, just for your information, that we're getting are around medical devices, the role of medical referees, and I've seen one on that one in particular, and the medical referee transition period. So I'll make sure to cover that off. I should also say that following the engagement that we've been doing since the publication on the 14th of December of the DH regs and the plain language document, we have been thinking about putting together a Q&A, which I know Susie has referenced. If I can't answer any questions today, our intention is to cover those off in the Q&A, so do pop them in the chat, and if I can't answer them, we'll try and include them in there, and we'll make sure that that's circulated around to you. Before I get onto the questions that we hear most often, I'm going to talk to you about the changes in relation to Form CREM 4. As you will probably all know, currently in non-coronial deaths, a medical practitioner completes Form CREM 4, and MRs use this, medical referees use this information to understand the cause of death and to decide whether to authorise a cremation. Under the new system, the medical examiner's scrutiny is going to make the Form CREM 4 obsolete, so that form and the medical referee's requirement to scrutinise it will be removed. I'm going to come back to that point in a question in a second, because I've seen some questions on that, but I'm just going to briefly move on to the other questions that we often hear about. So David spoke earlier about medical devices, but just to clarify, currently information about medical devices and implants is recorded on Form CREM 4, but as I've just mentioned, Form CREM 4 is now going. So under the new system, that information is going to be included on a number of different forms. So that is the MCCD, the certificate for burial or cremation, the green form, the certificate of coroner and the coroner's order for burial, so that's Form CREM 6 and Form 101 are going to be amended so that the information can be included by coroners where available. As William set out right at the start, a number of hours ago now, a number of these, there are legislative requirements, changes for legislation that we need to be working on, because a number of these forms are statutory. I won't go into the detail of that, but as William said, that has to come in a certain order, and that is kind of ticking along in the background. I'm going to move on to the role of medical referees under the new system. I know there have been a number of questions about that. So again, as I'm sure you'll all know, it's been decided that medical referees are going to be retained for a transitionary period. That was designed as a safeguard to ensure that the new system has time to bed in and to allow for analysis of how it's working. So currently, as you'll know, medical referees are responsible for authorising a cremation. So during this transition period, MRs are going to continue to complete Form 10, CREM Form 10 or 12 or 13 as appropriate. And we're going to be using the transition period to continue to engage with medical referees and cremation managers. Both of those will know that there's currently a survey live, and just this is a little plug to make sure you complete that by the end of the month, so we can use that to understand what changes are going to be needed. We've committed to giving at least 6 months notice before the end of the transition period. The survey that I just mentioned is really your opportunity to engage with that policy thinking. I saw a question around the processes for cremation managers and whether that's going to be changing. Their role is going to be remaining the same. The changes are around transferring some of the scrutiny that the MR currently does to the medical examiner, but the role of the crem manager will remain the same. I also saw a question which was around what forms are going to be getting to cremations, to crem managers, or to crematoriums, the word I'm looking for. And so just to clarify, the MR will continue to receive the application for cremations, that's Form CREM 1, the green form, and where relevant, they'll receive Form CREM 6 or Form CREM 7, and then the MR will complete Form 10 or 12 or 13 as appropriate. I think that's all of the questions that were in the box as everyone else was speaking, but if there is anything else that people would like to know, do say. And as I say, if I can't answer it now, we're working on this Q&A and we'll try to cover as much in that as we can if I can't give you an answer immediately today.
Thank you very much. If you don't mind taking a couple of questions, I've had some in advance, and as I know you have, crematorium medical referees have been really engaged in this whole process, for which I'm very grateful. One question is, how will the transitionary period be monitored and assessed? Will crematorium medical referees be asked for feedback, for example, on how it's worked? How will that decision be made about the future of crem refs?
So the starting point is this survey that's currently with MRs and crem managers, and I think that survey closes at the end of the month, and then we're going to be working with analysts to understand that data. Kind of depending on what we get out of that, we'll figure out what additional surveying we'll be needing to do, but we will continue to engage really closely. You guys are the experts. We want to understand what's happening on the ground, how the new system is bedding in, and just continuing to engage. We have a number of fora where we engage with medical referees. If there are any others who want to provide feedback or input, we're always open to that, and we will clarify as we get information, but it kind of depends on the information we get out of the survey that's currently live.
Thank you. Will crematorium medical referees see the MCCD, or will they just have the green form from the registrar?
So one of the changes is that they won't be receiving the MCCD; they will just be receiving the green form. But as Alan was explaining earlier today, the idea of the MCCD is that it represents the agreement of the cause of death between the medical examiner and the attending practitioner.
Thank you. There's a few questions about medical examiners taking on the roles of crematorium medical referees, which is not strictly what's happening. What's happening is that many of the roles of the crematorium medical referee have already been taken on by the medical examiner and by other reforms. And therefore, the question is about the need to continue to have crematorium medical referees, which is why there's going to be a transitionary period to make sure that everything remains covered. So this isn't about medical examiners being asked to do their job. Somebody asking who will be completing the cremation forms. There will be no cremation forms. So nobody will be completing anything. Nobody has to view the body. There will be no cremation forms. This is because medical examiner scrutiny is in greater detail than that crematorium medical referees currently undertake, because they have access to the whole medical record rather than just cremation forms. And so this has replaced the need for cremation forms. You've already got somebody independent scrutinising the death. Yes, somebody saying if there's no cremation form, I presume no cremation form fees. That is correct. Okay, so Laura, thank you so much. We will obviously forward all of these questions to you, which I know you'll take into consideration along with all of the other responses to your consultation. If people haven't seen the link, Laura, to that consultation, how might they access it?
It's gone round to all MRs and crem referees. If you haven't got it, get in contact with your crem manager who should have received it, and if not, let us know, because we think we have a complete list and there may be a gap.
Thank you very much. That's great. Okay, thank you. So that brings us on to the last of our speakers today, and I'm delighted that we're back to Dr. Alan Fletcher, the National Medical Examiner, very appropriately, to give us some idea of what this means for actual medical examiner implementation in the statutory system. Alan, thank you.
Thank you very much, Susie. Yes, this time I don't have slides, and I mulled over in my mind how much I'm able or could say at this point, and I decided that this was going to be a relatively short briefing. One of the main reasons for it being a short briefing is because you've had an awful lot of information condensed within 3.5 hours today, which has covered all aspects of the death certification reforms. And I'm very grateful for colleagues in government departments and the ONS to provide those updates, because it sort of brings together a lot of the challenges that we face currently into the space that will be the new system when the system commences. I thought I'd say at the start that, like many on this call, most even, that I am also disappointed that there was no announcement of a commencement date today. I understand the reasons that William explained early on, but that doesn't preclude me being disappointed that we don't have that to enable you to take forward the next stages of implementation, which are complex and span 2 countries and in a very complex system. So where does that leave us? Well, my view is that at the moment, we already have a medical examiner system interposed between the existing constraints, existing practices of the regulations that we have currently. And it is worth reflecting that 2/3 of all deaths are currently being scrutinised by medical examiners, and the work of medical examiner officers and everybody connected with the process is already well-established routine, embedded and demonstrating its benefits. That's not to say that we should be complacent and say we don't need statutory regulations. Of course we do, because it is the mechanism by which all deaths not investigated by a coroner will be reformed and will take out some of those idiosyncrasies and challenges that we have in the current non-statutory system that lead to distress and delay on a number of fronts, especially for bereaved people. One of the objectives that we must have is that we can transition as seamlessly as possible to the full statutory system. That is, that there isn't a big change on day one, whenever that date is, subject to ministers and Parliament deciding. There are a number of reasons for it, but primarily it's about bereaved people. And we do have this slight paradox at the moment, which reflects medical examiner offices doing their level best to engage with stakeholders, especially in the non-acute sector, but quite reasonably, in many cases, the question returns, but it isn't statutory, so why do I have to do this now? Within NHS England, we can influence that. Some of that goes to communications through my colleagues in as directors of primary care and the national medical director to influence people. It also gets cascaded down through integrated care boards and integrated care systems, because they are emerging as a key partner in the implementation process. It is important to consider what should we do, what should you do, medical examiners and officers primarily, as next steps between now and whenever that implementation date is. My view is, I suppose, summarised as keep going, please, because you are doing an amazing job at engaging and encouraging and scrutinising deaths, providing a very valuable service. I think it is also worth me stating that I do not consider medical examiners and medical examiner officers as ambassadors or change management people for the whole of the death certification reform system. Today has enabled me to think this is a shared responsibility, that there are other partners in this within other government departments and other stakeholders who cannot sit on the sidelines and wait for medical examiners and officers to come to them to unlock all the processes. There are lots of different stakeholders, and I know that engagement varies around the countries, both countries. But we are able to influence and explain, and I hope that this information sharing event, publications and future events and communications will inform your efforts to engage further with other partners as we approach the implementation date. From an NHS perspective, that is especially at a local level at trusts and integrated care boards, supported by all the regional medical examiners and regional medical examiner officers in England. And I know that Wales have their own strategy for engaging and rolling this through. The other things that you can do are to continue to extend the system and your proposals for out of hours, beyond office hours cover, because that's an important critical component of the medical examiner system. You can ensure that there is recruitment to any vacancies or posts that you have, and it's important that we have everybody in place because there are training requirements, as we've discussed earlier on. And please, can you plan ahead for the year ahead? I mean, that doesn't necessarily mean a statutory system being contingent, because you can still plan your systems, your access to records where you can establish them, your recruitment, as I've mentioned, and those engagement processes. I know that there has been a lot of discussion in the questions about funding. This is not the right forum to discuss budgets and funding. I'm not dodging the question. I just think this is a webinar concerning regulations and what they mean for a statutory system. But I am going to say this at least, that is, funding is not within my gift. It as William has pointed out, the funding for the system is devolved to the NHS as a whole, and decisions about increasing budgets are outside of my remit, very much well above the role I have. I always do my best to influence ensuring that we have adequate funding to deliver the service that we provide. I do appreciate the challenges. I get that. But I would also say that money is tight, and that everyone within the NHS makes a petition for increased funding at some level. It's a complex matter, and we are at the cusp of being able to communicate details for the forthcoming financial year funding within the next few weeks. Finally, I'm just going to give you what my commitments are to this process. One of the most important commitments is that I will continue to work with other government departments and stakeholders to ensure that your questions, your concerns, your valuable feedback today are considered when we take the next steps collectively to advance these important reforms. They will certainly influence guidance, whether the guidance is that which accompanies the regulations and my guidance as the National Medical Examiner to you on aspects of practice. I want you to feel reassured that I have your backs. That is, I will set out matters that I hope will reassure you that you can continue good practices that you currently have that work to the benefit of bereaved people while being safe and within the law. I will also work with the Royal College of Pathologists on the training and e-learning refreshings and updates that are needed to ensure that continuing professional development, knowledge and information sharing carry on through that route. And finally, my commitment is that we in the National Medical Examiner team and my regional medical examiner colleagues and colleagues in Wales will do our level best to ensure we communicate as clearly and as quickly as we possibly can about any new developments so that we keep up a drumbeat, especially when we approach that all-important commencement date. So finally, I realise that Susie is going to talk next. I don't get an opportunity to say it, but I'm going to say thank you to Susie on behalf of all my colleagues who've spoken, and I hope the audience, for convening this webinar. It's no mean feat to be able to do so for over 700 people and to do it so well. And my thanks also to the college team who have facilitated the wizardry that is Zoom that enables it. I will be in touch with colleagues as and when, and in the meantime, please may I also take the opportunity to wish you a happy new year, because 2024 looks like being a really significant year for the medical examiner system and the death certification reforms.
Thanks, Alan. Are you happy to take a few more questions?
Of course, yeah.
Thank you. There've been quite a lot of questions about out-of-hours services, particularly for faith deaths. What will be the requirement for those in the statutory system? Because at the moment, for example, it's possible for the MCCD to be issued without immediate medical examiner scrutiny. Will that not be possible in the new system?
All deaths not investigated by a coroner must have medical examiner scrutiny and confirmation. So wherever put simply, if ever an MCCD is written and is used to be with the intention of registration, it has to be confirmed by a medical examiner, and the only way that can happen is through scrutiny.
Thank you. Also some questions about an online case management system, which was mentioned some time ago. Is that still happening?
There is a development of the online case management system. It is not my responsibility. It is commissioned by the Department of Health and Social Care. They are responsible for its development through the commissioned operatives that are NHS Business Services Authority. Whilst it's got NHS in front of it, it has nothing to do with me. I obviously support a worthwhile, helpful and constructive case management system that could be used nationally within England. Wales, I know, have their own system, and that's fine because clearly they're a different country, but operate the same processes. I will give my assurance that I need to be assured that the system, as it is developed and rolled out, is fit for purpose, and I will. I reserve that right at the moment.
Thank you. There have been several questions about indemnity for medical examiners. Obviously, we've been advising during the training that medical examiners should contact their medical defence organisation to let them know that they're working as a medical examiner. But in the majority of cases, that hasn't been linked to any increase in subscriptions. The role and responsibilities of the medical examiner could be argued to be significantly increasing in the statutory system. Do you anticipate that there will be any need for increased indemnity?
Thank you, Susie. First, NHS indemnity should apply from an employment perspective, because all medical examiners who are fulfilling the role will be employed by NHS providers. The second point is that, of course, does not mean that personal insurance and indemnity is usual for medical practitioners. I'm not sure that I agree that the statutory system confers additional responsibilities other than what they do now, what colleagues do now. It's still a clinical decision. It's still similar processes. There's simply a declaration that's being signed. I would be very surprised if defence organisations saw this as a different system and therefore attracting a different tariff.
Thank you. There are several questions about from perhaps some of the GPs on the call today, saying they haven't been contacted by their local medical examiner office. What would they do if they want to try to engage with the local service?
Right. Well, first of all, thank you for joining the call and for highlighting that is excellent news. I mean, the process of engagement is a rolling one, of course, and we know that within England and to an extent Wales too, the offices have been at different stages of maturity and capacity. There have been all sorts of reasons why offices may have taken time to recruit and to extend out into the non-acute sector, including general practice cases. There are some practices that have not been contacted, is unknown to me, but I would say that please get in touch with your regional medical examiner or local medical examiner, lead medical examiner office in your locality to discuss the next steps, because I'm sure that that contact would be most welcome from the other direction.
Can I just say, as a lead medical examiner, just try talking to your practice manager first. We've recently found we had three GPs got in touch by a circuitous route to say we're really interested, and we pointed out that we'd emailed their practice 3 times over the last 6 months asking if they'd like to engage, but unfortunately those emails had not reached the general practitioners. So perhaps ask your practice manager first if they may have some information. Otherwise, your local hospital has a medical examiner service, and if you contact them, they will be able to put you in touch with the MEs, who will be delighted to hear from you. Alan, thank you. There are some mentions in the regulations about medical examiner performance and standards and so on. Will those standards be published, and how will medical examiner performance be assessed or monitored against it?
Yeah, thanks, Susie. Yeah, as you might imagine, during the non-statutory implementation phase, my focus has been primarily on implementation. As we transition to the statutory system, that we will have more of a role of surveillance and business as usual, business continuity. Within the good practice guidance, we will review, revise, and enhance the information regarding, I don't like the word performance, because I think performance implies some sort of performance regulatory management, and that's not where I sit with this system. Each case is a clinical judgment relying on the experience and knowledge of an individual practitioner who brings their own skill set and personality. That said, assurance that we have already published a good practice series guidance on quality assurance, which is effectively benchmarking and giving some pointers on that and escalation matters. My view is that is at the moment the document that you should be working to, and if we upgrade, improve, and clarify, we will do so in the good practice guidance. I don't see great changes, however.
Thank you. Jumping back to an earlier question, how is the medical examiner system in the statutory phase anticipated to interact and affect the child death overview process, the child death review?
Yeah, thanks, Susie. I know that child and neonatal deaths are of particular interest and prominence. I would say that all deaths are and have a bereaved person at the centre of it, and therefore all deserve appropriate attention. And I think that is reflected in the regulations, which say that all deaths not investigated by a coroner must have medical examiner scrutiny. That means all child and neonatal deaths as well that are not investigated by a coroner. There are, of course, relatively few of those contrasted with adult deaths in England and Wales, but they're no less important. There is a statutory process for review of child deaths, including the CDR process and the CDOP down the line in several months' time in many cases, and where it's relevant, a perinatal mortality review tool. We've published guidance again on the interaction with the in the non-statutory system with the child death review process. As the child death review process is already statutory, a lot of what is included in that guidance holds true because we attempted to future-proof it. We will review it in case there's anything new, but it is, as I see it, business as usual that deaths will still be reviewed, and where it is helpful, information is passed to the CDR or CDOP process from the medical examiner office as a source of information. There's no barrier to that. Talking is good. Communication, information sharing like this within appropriate reasons is encouraged, of course. The whole system is about transparency and openness.
Thank you. Please can I come back to a question that you may not have the answer to, but it's definitely something that even after I asked it earlier, there were a lot more questions about it. And it's the issue of there being a cost to trusts to access GP records, either to have a license or to be able to access System 1, for example. Trusts don't have a budget for it. Medical examiner services don't have a budget for it. What happens if you get to a stalemate and nobody will pay for the license and you can't access GP records?
Oh. Yeah, you're right. I don't have an answer for that. What I can say is it's an evolving process, if I may. sharing access is this is an IT conundrum, and there are initiatives afoot nationally, because this doesn't just hold to medical examiner processes. This is about sharing records in general for all sorts of possible reasons. And whilst a single solution would be obviously a holy grail, I'm not sure how close that is. Whether that actually whether that is actually achievable before the commencement of the statutory system is outside of my knowledge. But certainly we are in continuous contact within NHS England, at least, of those who have responsibility for IT systems and governance. So if there's any new developments at all, we will communicate them as quickly as possible.
Thank you. And I've been multitasking while we've been talking, and Chris has just posted a link for any GPs who are not aware who their medical examiner service is. There's a link there to the NHS England website, which has a link to every medical examiner service. So you should be able to find the contact details there if you need to find them. Thank you. Thank you, Chris, for posting that. A question that came up a couple of times, which is about, as you know, medical examiners will often hand a case on from one ME to another because, you know, different stages are done on different days and with different availabilities. Professionally and legally, where does the medical examiner stand signing off another medical examiner's review when they haven't done the case themselves? Are they being expected to scrutinise it themselves a second time to make sure that they're signing it off to the best of their knowledge and belief, or can they rely on the previous scrutiny of the first ME?
Thank you, Susie. Yes, they can rely on the previous scrutiny within reason, of course, and that's why there must be a record of the scrutiny of the thoughts and reasons for decision making that the first person had done. Kind of just think about this in a slightly different way. At the start of my first talk, I talked about the components of scrutiny: proportionate review of relevant medical records, the interaction with an attending practitioner, and the interaction with a bereaved person. A further component of scrutiny is the confirmation of the medical certificate of cause of death. So there's a sort of fourth one, the natural conclusion of scrutiny. And we already have two of those components delegated in many cases to medical examiner officers who we entrust entirely for conduct parts of scrutiny. I see no difference for a medical examiner who brings everything together to confirm the cause of death with the information available on the medical examiner's review of records and their thoughts, the interaction with an attending practitioner, and the interaction with a bereaved person, which may well have been by a medical examiner officer, who brings that together at the point of confirming that medical certificate as the conclusion of scrutiny. I think that is, I see that as the logical, it's a process, not a person.
Thank you. Will you be updating the good practice guidance for medical examiner officers in line with the statutory system?
Yes. Nick Day, my amazing policy and program manager, and my supported by my amazing team of office coordinator and senior project manager, has that already on his desk and is doing so as best he can, subject to the finalisation of regulations and the whatever final tweaks are made.
Thank you. I just spotted a question and I've lost it again. It was a tricky one.
Oh, good.
So maybe you're glad that I've lost it.
The rest haven't been? Okay.
Okay, my tricky question is, I know some areas are doing extremely well with review of community deaths, but in other places, GPs are not keen to engage until they absolutely have to in the statutory system. I know medical examiner offices are doing what they can to try to get people on board in good time. But what happens if there are a significant number of GP practices that will not engage until the day the system becomes statutory, because it's not really a switch that can happen overnight in a split second?
Right. Two elements of this. The first element is about engagement, and I fully acknowledge how challenging it can be to engage people in a non-statutory system when, understandably, their focus and attention is directed elsewhere for other pressures. I understand that entirely. That doesn't mean to say that you can't try, but there is a hierarchy of escalation. I think there is so far that one can go as a medical examiner service locally to achieve that. I think you need friends and support. If I may suggest that some of those friends and support may well be those within the trust which hosts the office, outside amongst other important stakeholder groups like network leads, and at the next level up, the Integrated Care Board, all of whom have been contacted, engaged, and informed, especially in the light of the publication of the draft regulations. The support that can be offered from a regional perspective, that is the regional medical examiner and regional medical examiner officer, is invaluable, and they have a connection to the regional medical directors. At a national level, I do that through the National Medical Director for Primary Care and the National Deputy National Medical Director. And of course, we are communicating and sharing this information with other stakeholder groups representing general practitioners, including the BMA. The question comes: what happens if we get to a date and there are practices that have not engaged at all? I think there are elements of this. There are those that have simply said, we're not talking to you at all, whereas in fact at least around about 2/3 of GP practices, when we last looked at this approximately, had at least made contact and there was a dialogue, which is important. And then finally, because I'm going on a little, I realise I was going to say this. On day one, not everybody's going to die at once. We know that on average, per general practice, a death occurs on average, I know there are different configurations, once every 2 or 3 weeks. I would say that if an office that manages 10, 14 deaths per day, and we know that 50% of those are probably in hospital broadly, to be confronted with, say, if only 50% of their GP practices have not engaged, then at worst that would be 3 or 4 deaths per day to start with, that they may have some unblocking, some queries, and some readiness for that day, and probably for the few days afterwards, about a fortnight. I would advise medical examiner offices to be ready to have to be spending some additional time on telephones, etc., and bolstering their office support to accommodate that. But we're not quite there yet. We'll give some further thoughts to that.
Brilliant, thank you. I'm going to have to draw that to a close now, Alan, as we're coming to the end of the session. Thank you very much for all of that. So I think we have got through a huge amount today. We've had over 600 questions and over 350 of them have already been answered. I appreciate there's still quite a lot of questions still needing to be answered, as do all of the government departments and other stakeholders here. We do realise that not all the answers are available now, but the plan is to answer those when it's possible to do so. This definitely isn't the end of the communications around the reforms. It just forms part of it, and I'm delighted that so many people have been able to attend. I'm very grateful to all of the speakers for their contributions today and for working so collaboratively, and their teams, to get the reforms to this stage and to put on today's webinar. So what happens next? We will edit out the break and circulate the recording to all of you who have registered. You are welcome to share it with colleagues. We will at some point put it on the college website with a link so that it can be watched back by people who would like to do so. A CPD certificate for 4 hours of education will be sent to you if that is of any use to you. That will be emailed to you by the college team. All of the speakers today and their departments are working on a Q&A doc, a frequently asked questions document, and that will continue to be developed and then will be shared widely as soon as it becomes available. And information will be shared via various other communications routes, as William mentioned at the beginning, perhaps a podcast, or maybe some recordings of some discussions, which will then be circulated and can be accessed easily remotely without having to register, without having to pay anything more, and without having to be actually available at the time that the discussions are had. This has also given me a lot of ideas, specifically really for medical examiners, for topics that it would help to have more in-depth discussion, and perhaps something that we could develop some online webinars for medical examiners as we go through the transition to the statutory system. So we have an opportunity to look at those in much more detail. So finally, thank you again to all of the speakers. I'm very grateful for you giving up your time. Huge thanks, as always, to the college team who have put in so much work in the run-up to this, registering and communicating with over 700 delegates and making sure everybody has all the links is no easy task. And Carla and Chris have worked extremely hard behind the scenes, and I'm very grateful. I'd like to thank all of you, the delegates, for your engagement, for your questions, and for your interest in the reforms. And your questions have really helped us to understand the concerns out there and where we need to focus future communications. And thanks to all of you, really. I hope you've enjoyed it, and we'll be in touch soon with more information. Thank you. Could I ask the speakers to stay on the line if possible, just for a couple of minutes for a debrief? And if all of the delegates could sign off, that would be great. Thank you.